Hi, this is Laura Gayton from the Joint Commission, and I serve on the Board of Directors, and I just want to wish the Alliance a very happy 15th anniversary. Congratulations.
15th anniversary. Keep it going and keep improving.
Ramona, we're ready for you.
Thank you. Welcome back to day 2 of the National Donor Management Summit. We're glad to have you with us today. My name is Ramona Chapman. I'm the Community Outreach Manager and MOTEP Director for Gift of Life, Michigan. I'm also privileged to be a member of the Summit Planning Committee. We have an incredible lineup of presentations for you today, but we want to take a quick look back at some of the fantastic discussions from yesterday. During our sessions on change management, as well as the panel discussion on allocation changes, we invited our live artists to capture highlights from this conversation. Let's take a quick look back at how these highlights turned out. What a fantastic way to showcase these insights. Now, if you'd like a copy of these sketch images, you can visit Organ Donation Alliance, that's all one word, .org, and click on News. We're excited today about our topic as we kick off this day, why are social inequities a public health crisis? Now, before I begin today's keynote session, we'd also like to extend our thanks to our event sponsor, Paragonix. Paragonix Technologies markets organ transportation devices that safeguard organs during the journey between the donor and recipient patients. Their Sherpa Pack cardiac, pancreas, and kidney transport systems are the only commercially available FDA-cleared transport devices for transportation. They are also developing a device for lungs designed to improve organ quality and extend transport time. For more information, visit paragonix.com. Now it is my pleasure to turn to today's keynote. It is commonly known that minority populations are at a greater risk of organ failure from renal and liver diseases and have a decreased likelihood of receiving a transplant. Based on that, it's important to address the social determinants of health to drive change and end health inequities within the field. In the chat, I'd like for you to share with us What actions are you currently seeing or doing to address inequities in organ donation and transplantation? So this is your opportunity to be interactive with us. And what would you like to see in the future? To discuss this topic on today, we are pleased to welcome Dr. Winfred Williams, the Chief of Nephrology and the Founding Director of the Center for Diversity and Inclusion at Massachusetts General Hospital. Dr. Williams, good morning.
Good morning, Ramona, and thank you so much for that kind introduction. And I just want to begin by saying that I'm happy to be here this morning to speak on behalf of the Alliance National Donor Management Summit. Happy to be here. So in the next half an hour to 40 minutes or so, what I want to focus on are the social and other determinants of disparities in renal disease with transplantation as a model, focusing on donor aspects as well as some of the barriers to kidney allocation that have affected disadvantaged minority populations, and then to look at remedies to address some of the social determinants of health. I think we're all set to advance the slides here. And so, okay, so my research focus, just by way of sharing this with you, is health disparities on a national policy level in transplantation and molecular biomarkers in kidney transplantation. And I have no disclosures related to this presentation. So I thought I'd begin by focusing on a definition of health disparities as it relates to health equity. And this is work from my good colleague, Tangela Purnell at Johns Hopkins. And in fact, Dr. Purnell and Dr. Majewski were co-presenters for a AST, American Society of Transplantation webinar on social determinants of health. And they have helped inform this presentation. So let's begin with health disparities. These are preventable differences in the burden of disease, injury, violence, or opportunities to achieve optimal health that are experienced by socially disadvantaged populations. And so when you make the translation to health equity, that occurs, of course, when every person has the opportunity to attain his or her full health potential. So in conceptualizing disparities in health and healthcare, there are, I think, tiered determinants that depend not only on social determinants, but other processes of care and the structure of care that may present barriers to, for example, the realization of kidney transplantation. And in this slide, you can see, moving to the left panel here, system level barriers in terms of healthcare access, the organization of care in a particular healthcare system, the quality of that care, and whether quality care reaches out to communities that may be vulnerable. If you move up to the orange circle there may be provider limitations in terms of the provider's knowledge of the communities he or she may be interacting with, and whether that provider is culturally competent, has the right communication skills to reach out to vulnerable populations and partner in an effective way. And then if you're moving up that tier to patient level barriers, they may be demographic, they may be socioeconomic barriers. We'll look at those in more detail. There may even be inherent biological barriers to transplantation and personal patient preferences. And I'll cover some of these various aspects in this talk. But this all is affected in the bottom line there by the environment, the interaction of geography, of poverty, of segregation, social cultural norms that feed in to the processes of care, structure of care, and then lead to disparate health outcomes, medical complications, rates of mortality, functional status, and quality of life. And again, this is a slide that was provided to me by Dr. Majewski. So the objectives for this talk in the next half an hour are to describe the nature of disparities in end-stage kidney disease and kidney transplantation in the United States, to identify factors that are driving disparities in transplantation, using kidney transplant as a case study model, and then to highlight examples of multi-level strategies that are designed to address disparities in transplantation. And so I would ask you, and you might ask me, well, why is this topic so important? And I think the impetus for really focusing on this area is the renewed effort in the aftermath of the racial reckoning over the past year and the broad public outcry after the murder of George Floyd, where we have been focused now on addressing systemic racism in society writ large, but also in medicine, and so-called racialized medicine that may result in clinical constructs that do harm to communities of color have come into great focus. So I'm going to give you sort of a broad view of some of the nature of disparities in renal disease, again, writ large in terms of some of the epidemiologic data that we know have a bearing on this topic. So I'm sure many in this audience know that the overall incidence of end-stage renal disease in African Americans is fully about 3.5 to 5 times that of whites. And African American patients constitute fully about 1/3 to almost 1/2 of the dialysis Medicare population in the United States. Non-diabetic kidney disease afflicts Black patients disproportionately, and in one study, the rate of nephropathy associated with HIV infection among Black patients was some 50 times that of white patients. And acute and chronic kidney disease, again, I'm sure this audience is well informed, represents a worldwide public health problem. Variation in the incidence, prevalence, and outcomes by race may reflect differences in geography, race, ethnicity. There may be ancestral markers, for example, the biological factor that's engendered in genetic variation around apolipoprotein L1. This is a gene variant that rose to natural selection during African sleeping sickness outbreaks in sub-Saharan Africa prior to the migration that was engendered by slavery. And APOL1L1 genetic variation, G1 and G2, are protective in these populations against trypanosomiasis. These variants traveled with the slave trade, and now some 10 to 13% of African Americans carry these genes. And if you were an African American and you're homozygous or compound heterozygote for G1 or G2, you have an increased propensity for chronic kidney disease and progression to end-stage renal disease. There may be socioeconomic and behavioral factors operant as well. And then there's always the issue undergirding all these factors of access to care and access to quality health care. So again, of the more than now 600,000 individuals with end-stage renal disease in the United States, approximately 1/3 are Black individuals. And there are unmet goals in chronic kidney disease care for African Americans. We know that patients who are Black have challenges around some of the best metrics of good care and good outcome when you are looking at a dialysis population. Anemia and high blood pressure control are challenges. Timely referral to subspecialty nephrology is a big problem, and late referral leads to increased morbidity and mortality. The placement of dialysis AV fistulas or AV grafts in a timely fashion is a challenge. And once one starts a dialysis replacement therapy, achieving dialysis adequacy and then, of course, access to transplantation are challenges for Black patients in the end-stage renal disease population. Now, these are projected growth curves for prevalent dialysis and transplant populations in the United States. And what you see here, and it's hard to see, there is a blue line and a dotted orange line superimposed on these solid blue and orange lines. These are Markov modeling data based on data through 2006 that made projections for the prevalent populations of both dialysis and transplant patients. And you can see that the modeling in the dotted line absolutely linearly maps really precisely to these solid lines. And so again, the prediction was that by 2020, the dialysis patient would exceed 500,000 patients, and the transplant population more than 250,000. And in fact, these data are borne out, and their inexorable climb in both populations continues. And so we often ask, then, what is the best renal replacement therapy? And this is data that's informed by our colleagues at the University of Michigan, Bob Wolf, Fritz Port, at the Brigham, Edgar Milford. And this was a seminal study in 1999 in the New England Journal, looking at the death risk, the relative risk of mortality, if one remained on dialysis as compared to undergoing transplantation. And what you see early on at day 0 on the slide is a 2.8, say threefold relative risk of death if you're after transplantation in the line that's moving down diagonally. And that's related to surgical misadventures, wound dehiscence, infection, and so forth. But once you pass the line of reference at 1 there, the dotted line, at 166 days after transplantation, your risk stratification is equal to those who are staying on dialysis. And if you have a well-functioning kidney transplant beyond 106 days, you can see that there is a durable survival advantage to those patients who have well-functioning kidney transplants. And so we generally feel in the renal community that nearly all waitlisted chronic renal failure patients are predicted to live longer with a better quality of life if you can afford, if you can realize the opportunity for kidney transplantation. Again, not only a better quality of life, but also an increase in longevity. So if you look at disparities across the kidney transplant trajectory, what I want to outline in the next several minutes are the multiple barriers, the hurdles to achieving the outcome that's desired here, and that is of a first kidney transplant. And so you can see here, we talked already about the rates of kidney failure in African American populations. But then there are tiered barriers, as I say, or hurdles, getting to the point of realizing a kidney transplant. And that's in the first instance of getting referred for kidney transplant. And then after you were referred, getting an evaluation in a transplant center. And then after that evaluation, which is really quite extensive and labor intensive, getting placed on the national kidney wait list. And then realizing hopefully either a deceased donor, a live donor kidney transplant. So again, tiered there are milestones that have to be achieved to get to the point of a successful kidney transplant as the desired outcome. And if you look at the conditions for allocation in the United States, this slide sort of is a snapshot of it. In pink, these are patients who are, you can see a broad population on the waiting list. And for kidney transplantation, this exceeds about 95 to 100,000 individuals, and there are about 17,000 kidney transplants that are performed in the United States annually. So what this means is that demand far outstrips supply, and our challenge really is to allocate a scarce resource where, again, demand greatly exceeds supply, and this means that we need to make trade-offs based on values and guiding principles. Now, this was another seminal article, and many of these appeared in the late 90s and early 2000s. This is by our colleagues at the Harvard School of Public Health, Arnie Epstein and John Ianian, and this is looking again at those tiered level of hurdles to transplantation. And what they did in this study in a broad population distribution for large geographic areas in the United States is look at how many people actually achieve the kidney transplant outcome. And you can see here in the green bar, if you look at those patients who were first referred for evaluation in green, there's about an 8% difference with the differential favoring white patients between those patients who are referred for evaluation, whites compared to blacks. And then when you get to the point in the middle here in the blue bar of being placed on the wait list after evaluation, there's about a 15% differential between white patients favored over Black patients. But then if you finally look at who in fact receives our first kidney transplant in this study, and again, this was a seminal study at the time, there's about a 35% difference between the groups. Again, 35% favoring white patients achieving transplantation over and above Black patients who are similarly or equally qualified for kidney transplant candidacy. We've been able since 2014 to begin to narrow the deceased donor kidney transplant rates in the United States. And I'll show you some of the work that was folded in to achieve this outcome. And these are data looking at, again, a long period of transplant outcomes. And if you look in the deep teal, if you will, line here, the white rate of transplantation is decreasing over this period. This is deceased donor kidney transplant. And Blacks are either level in yellow or increasing. And this increase occurred after 2014. And I'll show you more granular data to that effect shortly. But if you look at the live donor kidney transplant, really an area that's of particular importance to this audience, you can see that Blacks languish in terms of live donor transplant throughout this period. In fact, live donor transplant rates in yellow here continue to bottom out, even at the most recent time point. So this is still a huge challenge in U.S. kidney allocation and renal replacement therapy as a function of transplantation. And this is shown well in Dr. Purnell's study with Dory, Segev, and others at Johns Hopkins. They looked here at a long period, about a 15-year period, almost a 20-year period of association of race and ethnicity with live donor kidney transplantation in the United States, the large data set exploring the rates of live donor transplantation in about 450,000 first-time adult kidney transplant candidates. And the bottom line here, this is a busy panel of charting here, but you can see in blue the lowest curves in all of these models, which have been adjusted for baseline confounders, adjusted for socioeconomic status, healthcare access factors, baseline and transplant center factors, and so forth. You can see that Blacks in the blue dots here trail all other groups in terms of their rates of live donor kidney transplantation. So this is still, again, a huge problem for Black patients in the United States. So let me turn your attention now to factors influencing some of these disparities in kidney transplantation. And so here's where we look at some of the thematic components of really the title of the presentation today. We're looking at some of the social and other determinants of access to kidney transplantation, donation, and on the recipient side. And there may be in the left quadrant here on the slide, population level, community level, barriers to transplantation. I talked about the chronic kidney disease burden. There may be geographical constraints in terms of access to transplant centers and access generally to quality health care. There may be community awareness deficits in terms of the best practices for kidney replacement therapy. Moving up this tier again at the health system level, we may confront insurance product constraints in terms of availability of kidney transplantation. Patients who are from disadvantaged areas, African Americans in general, have public products for insurance support as compared to private, more robust insurance support. There may be, again, information quality or educational quality deficits in terms of health literacy, outreach to communities, and then decision support to bring in vulnerable populations for the opportunity of transplantation may be lacking at the health system level. The provider level is an important area, moving up another tier in green. Again, I spoke earlier about the capacity of providers to reach out to vulnerable populations, to have culturally competent communication skills, their perceptions of the suitability of African Americans, for example, to receive transplantation, and that may vary depending on provider and geography. Training, knowledge, cultural competence is key in the provider factors that fold into, again, these multi-level barriers. And then when we move up finally to recipient and donor level impediments, we're looking at the undergird of surgical medical mistrust that's well, I think, seated in the historical experience of some ethnic minorities in the United States. I hearken back to the Tuskegee experience as a historical, really, it's a linchpin of why, in fact, patients are very leery of engaging with the healthcare system in the United States. And of course, you all know that was the National Public Health Service experiment on African American men, where those men were infected with syphilis, and the natural history of syphilis was allowed to play out in that population without their knowledge, without their informed consent. And that's led to deep mistrust, I think, on the medical establishment by vulnerable populations. There may be social, cultural concerns, religious concerns. There may be, again, knowledge and belief deficits and so forth. Family structure, occupational structure, the economic cost of pursuing a transplant, all of these, again, fold in to provide a series of barriers that, to some extent, are hard to overcome if there's not a concerted focus effort to outreach to communities and vulnerable populations to help them, I think, surmount these barriers. COVID-19 has exacerbated and I think highlighted social determinants of health and disparities in healthcare. And this is a work, again, from Dr. Purnell and Dr. Cruz at Hopkins, in, I think, a very a valuable contribution on the perspective of this component of racial disparities in kidney disease, the consequences to Black patient, social isolation, food insecurity, food scarcity, loss of employment, loss of income, loss of insurance and medication coverage, the exacerbated fear of institutions, really leading to vaccine hesitancy and denial, care delays, disrupted access. All of this was exacerbated, is the point here, by the consequences of COVID-19 to the ethnic minority populations. And we know that ethnic minority populations, Blacks and Hispanics, had outsized rates of infection with COVID-19 and increased rates of hospitalization and increased rates of mortality as a result of this pandemic. And then there are a number of recommended remedies to mitigate this disparities, which we'll come to in some of the final parts of the talk. So I wanted to take a bit of a tangent to look at what in fact is structural racism and why it's important. And I think this is really important because it undergirds, this issue undergirds a lot of the social constructs, social determinants of health disparities, mechanisms by which societies foster racial discrimination through systems of housing, education, employment, earnings, benefits, banking, access to credit, media representation, and then this dovetails to lead to healthcare disparities. And of course, the criminal justice system is a part of this systematic reinforcing of discriminatory beliefs, values, and distribution of resources. And I think one important example, which is shown here graphically, is the legacy of residential segregation in U.S. cities, including the practice of redlining, the drawing of red lines around portions of a map to indicate which areas in a city a mortgage lender should grant loans, which areas should not be granted that financial support. And this began really with an organized federal effort that systematically set up structures for racist policies that have effects now even to this day. It begins with the National Housing Act of 1934, the establishment of the Federal Housing Administration, the FHA, and in 1935, the Federal Home Loan Bank Board, the FHLBB, and this created then the offshoot called the Homeowners Loan Corporation. And this HOLC corporation created an inventory of some 239 cities to create residential security maps. And if one example, which I will show you here, is the example from Philadelphia, the appraiser J.M. Brewer, and the creation of the map of Philadelphia. And what you see here is the map. In the center there in gray is the core business and industrial area. And then outlined, spreading out from the center core, are areas that are red lined. And these are areas that are predominantly occupied by ethnic minority patients, individuals. And banks were basically instructed not to lend to these high-risk areas. And so you move out to the green areas and the blue areas in the suburbs of Philadelphia. These are so-called desirable areas for mortgage loan support. Now, this leads to very quantifiable outcomes, and I think to this day is played out in many cities across the United States. I'll give you one example close to home for me in Boston. In 2015, the Boston Federal Reserve issued a report entitled The Color of Wealth. And in that report, it indicated that white households in the Boston metro area had a median net worth of about $250,000, $250,000, while Black households comparatively had a median net worth of just $8. And the report found that close to 80% of white families owned a home, while just a third of Black families did, which means that Blacks have much less ability than whites to pass wealth on to their children, and that perpetuates a racial wealth gap. And the report said, unquote, these wealth disparities have deep roots in historical injustices such as redlining, school segregation, the racially uneven application of the GI Bill, and federal home loan subsidies that built the white middle class after World War II. And I want to tell you that in the Boston Globe, where this was reported as an expose on race in Boston, the next day after this expose came out, people were outraged and astounded by these facts. And there was a lead headline in the paper the following day: that was no typo. The median net worth for Black Bostonians really is $8. And people understood then, structurally, this is a huge, huge problem that needed to be addressed. So I've given you sort of a social economic and political context to macroeconomic policies that are focused on in this World Health Organization publication by Solar, looking at how macroeconomic policies spill through to have huge impact on labor markets, on banking, on housing, on land access, public policies, health being one of them, social protection, education. This all amounts to, in the left panel here, structural determinants, social determinants of health inequities that have to do with education, occupation, and income. Then you move to the right here, the intermediary determinants of social determinants of health. This has the material circumstances affecting the living and working conditions of patients who are vulnerable, their behaviors, their biological factors, psychosocial factors that inevitably have an impact on equity in health and well-being. So I'm going to turn your attention now to health policy and some of the things that we've done on a national level to address some of the barriers that we've been discussing heretofore. So many of us were involved for about a 10-year period in a 360-degree review of U.S. kidney allocation, looking at, for example, the mismatch in graft and patient survival, longevity mismatches, a 17-year-old kidney going to, for example, a 75-year-old recipient candidate with diabetes, that sort of mismatch, high discard rates, biological and ethnic inequities were a focus of this 360-degree review, and then a fragmented and non-unified allocation system across the United States. And so the goals of the kidney allocation system review were now to improve longevity matching and then have a focus on increasing equity in the system. And so what changed with the kidney allocation system in 2014 and became really a law in terms of distribution in 2015? What changed and why? What has been the impact of CAS? And I'll show you some of the impact in the next several slides. Now, I'm not going to go through all of the component changes for the sake of time, but I'm going to isolate a couple of them that were, I think, key. So the first thing, green here, is I'm going to show you waiting time calculation, how that change in waiting time calculation increased the rate of allocation of kidneys to ethnic minorities. So pre-registration dialysis time was added to the waiting time accrual that patients received on the National Kidney Transplant wait list. And then a part of my work and my contribution to these allocation rules is the blood type eligibility of transplantation across a minor histocompatibility barrier, that is the so-called transplantation of A2 and A2B kidneys into a blood group B recipients. I'll show you some of that data very briefly. So the problem that we're addressing here again is ethnic access and equity in transplantation. And let me show you another structural component here. This is another, this is a system level barrier. This is work from Rachel Patzer, Nancy Kuttner at Emory, the association of race and insurance type with delayed access for kidney transplantation among patients initiating dialysis in the United States. And what they show here is that if you're a young Black patient, 18 to 35 in the second category here with the circle, the odds ratio for being reported not assessed for transplantation is some 30%, almost 27% above the reference group. So young Black patients are much less likely to be presented the option of transplantation around this time of starting dialysis purely as a function of insurance type. Another example of a structural impediment to transplantation. If you look under CAS, Black patients after CAS was implemented were now receiving transplant proportional to their representation on the waiting list. And you can see in this slide, I don't have a pointer in the circle here in red, the pre-CAS transplant rate was about 31%. It went up some 5 to 6% post-CAS immediately in terms of deceased donor kidney allocation. And one reason was the dialysis time rule adjustment. So this is a percent of transplants to recipients with 10 years plus years on dialysis in terms of their dialysis vintage. And you can see pre-CAS, they're being transplanted at a rate of about 3 to 4%, 5%, and then a whopping increase to 19% post-CAS, a so-called bolus effect, which is now tapered down to 6 to 7%. But this was a measurable, completely profound impact on allocation to, for example, Black patients who had been on very long vintage dialysis rolls. And so CAS gives credit for pre-listing dialysis time. The patient starts dialysis, that dotted line is filled in now, and patients achieve waiting time points, not only when they begin dialysis automatically, but also, for example, if they're referred for a transplant evaluation, when their GFR has fallen to 20 cc's per minute. So waiting time begins to accrue right at those milestones. Now let me touch briefly on some biological issues as a function of ethnicity, and this is the blood group determinant issue that I raised earlier. And this is transplantation across a minor blood group incompatibility barrier, a blood group A kidney going into a blood group B recipient. How can we do this? The way in which this works, and let me just also say that blood group B waiting list candidates are relatively disadvantaged in relation to other groups, and minority patients happen to occupy 70% of the blood group B waiting list. And in terms of disadvantage, you can see that in this slide. Adult waiting listed patients who received a deceased donor kidney transplant in the middle panel, you can see that blood group type B are at the lowest percent rate for recipient of a kidney transplant as a function of blood group. And so what's the reason that this can be achieved? There's the distinction between A1 and A2 red blood cells. A1 or red cells have 1 million A molecules on the red cell surface. A2 red cells in the right panel here up top, or non-A1 red blood cells, have about 1/5 of the distribution of those molecules, about 200,000. And so that's a much lesser dense array of A antigen. And so what you see here in the bottom here, about 80% of the blood group A population are A1, about 20% are A2. And this also plays out in terms of antigen display in kidneys. You can see that in the left panel, if you're an A1 kidney, you have about a 3+ antigen expression by this German investigators, Bronner et al. And if you're an A2 kidney, you have traced to 1+. So again, the display of A2 antigen in A2 recipients is much less prominent. So we looked at this in a broad national study. This is the first report in the OPTN national variants, looking at the allocation of A2 and A2B deceased donor kidneys to blood group recipients. This was based on work from the Midwest Transplant Network that showed that these kidney transplants were successful. And we looked at about 9 donor service areas across the United States, including Alaska and including Puerto Rico. And so what we found is that there was robust graft and patient survival after transplantation of A2, A2B into B donor recipient pairs. You can see at the curve here that non-A1 or A2 kidneys do just as well as the B to B controls. These lines are really tightly matched. And in fact, the blue lines, the A2, A2B to B, are above in terms the red lines in terms of grafts and patient survival. And so this was folded in as a national allocation rule based on this work that we'd done for about 10 years, looking at precast rates of transplant of this kind of transplant. And you can see post-cast, and really to this day, the rate of transplantation is now increased for ethnic minority patients, and especially African Americans, at about 8 to 10% increased rate of transplant annually. I'm going to touch very briefly on geographic disparities in access to transplant for the sake of time. This is counties where minorities are overrepresented. You can look at the Eastern Seaboard, the Mid-Atlantic states down to the South and Southeast, through the Midwest and West, and the Southwest and Western parts of the country. This is a large representation of African Americans and Hispanics across the country, with the lion's share of African Americans in the southeastern part of the country. And if you look at median wait time by state, the longest wait times mirror those areas where minorities were really outsized in terms of their population rate. So I'm going to just close by talking about multi-level strategies to address some of the disparities we've been discussing today. These are individual clinic and transplant center approaches to reducing disparities, and there are many now. And for example, at Pittsburgh, pre and post transplant teams travel now to the underserved areas around Pittsburgh, to Mifflin, to Tuna, to Hammett, shorter appointment wait times for patients, all looking at designs to facilitate access to care. at Myskowski at the University of New Mexico, has an NIH-sponsored comparative effectiveness trial looking at culturally and contextually adapted interventions to, again, place patients on a kidney transplant fast track with peer navigators, helping vulnerable populations access to best kidney transplant care, improving kidney transplant related outcomes, looking at changes in cultural factors, knowledge deficit, and addressing the ambivalence patients often have towards transplantation. This is a culturally tailored diet, exercise, post-transplant program, improved nutrition monitoring of CKD end-stage renal disease patients, improving their knowledge base of live kidney donors and family members, really informing them about these opportunities, accessing the influence of COVID-19 that we touched on, and empowering CKD patients to actively participate in their care, improving patient-provider communication, patient-reported outcomes. At Hopkins with Dr. Purnell, my other colleague that I've spoken about here, a patient-centered, stakeholder-engaged strategies to address disparities in access and social support in transplantation, engaging families, faith leaders, patients and their families, community members, partnering with African-American faith leaders to assess the effects of COVID-19 and to develop a novel health equity educational curriculum in partnership with Hopkins investigators and trusted agents in the community. This is a key facet here, that you have to have trusted members of the community help as intermediaries in communicating and reaching out to families. The Health Freedom Path to Wellness, the Circle of Friends program, again, a novel academic community partnership to promote health equity. The Hopkins, you can see this online. They have equity online courses that are free. I put this website up just so to inform any audience member who might be interested. They are happy to have you reach out and look at the many resources they have available, again, to inform these kind of academic center-based community partnerships. So I'm going to close here and say that despite the many barriers that we've talked about, some of which are clearly potent social determinants, there have been national policy changes trying to address many of the disparities that operate in allocation for U.S. kidney transplantation. Racial and geographic disparities persist. I've showed you that on the race-based side, donor kidney transplantation still languishes in African-American communities. There are geographic disparities that exacerbate these race and socioeconomic disparities. We touched on them. I showed you several new national policy changes that are underway that successfully look to be mitigating some of the health disparities in access to quality kidney transplantation. And now finally, healthcare centers and transplant teams are at the forefront of enhancing outreach to the communities, bringing the care to the communities, and reducing disparities by those mechanisms. So I want to thank you for your attention, and I look forward to the Q&A session.
Thank you, Dr. Williams. Thank you for that informative and quite insightful presentation. At this time, yes, we will go ahead on and open up our section for questions from the audience. And once again, you may use the Q&A feature inside of the Day 2 session window to submit your questions. And we have until about 11:25 for questions. And so at this point in time, I don't see a question. So allow me to start by asking, Dr. Williams, again, we can see why this is such an important topic. And you talked about, and I love the whole concept of this interdisciplinary structure to address health disparities. And so I just want to ask you, what are maybe some of the other things that the organ and tissue donation and transplantation community can do to ensure that we are addressing these social, political determinants of health to make sure that we, again, are hitting it from every opportunity?
So Ramona, I would say, it's not enough for us to be well informed ourselves. We know about the issues. We know about the problems. We even know about many solutions to to use as innovations and interventions to address these problems. But we have to go out to the community. I think that's one of the key features I've learned in the last 18 months or so, that patients still need to have a high degree of health education and increase in their health literacy to even, for example, adopt appropriate strategies for vaccination. There's a lot of vaccine fear, vaccine hesitancy, and I think that's based a lot on, for example, misinformation on the internet, and even rumors that circulate in communities. So I think this dovetails to transplantation as well, that we have to get out there in the community and address folks where their concerns are really evident, and partner with, again, health navigators, peer navigators in the community, social workers, community health workers, and community-based organizations that will help address unmet needs. And I think we're only beginning now in an organized and focused way to take our work outside of large academic medical centers to the community.
Okay, thank you, thank you. I am excited about that as a person who has been involved in community education for many, many years, to see that there is definitely an appreciation on a different level to make sure that all of these different factors are being involved in making sure that messages are getting to communities appropriately in the language that is needed for them to understand, engage, and to realize that, there are various parts of our community that we have to have involved. And so it was great to hear about the faith community and, again, other social organizations that people are involved in to make sure. I don't see any additional questions.
If I can add one other thing, I think another part of this is not only that piece, which is a huge part, but we have to hold ourselves accountable too. And what I mean by that is there need to be more persons of color like us who are transplant professionals going out to the community. And in order for that to happen, folks like us have to be a part of the transplant network. So I think there's still a lack of minority professionals who have the expertise to go out to communities. And I think that's a part of the whole infrastructure for who gets appointed to do various leadership roles, as well as getting appointed to faculty and so forth in our major medical centers. And so that's still a focus for us in terms of increasing the number of those who are underrepresented in medicine to come, build their careers in transplant centers, and then have that work go forward to the community. The other part of accountability is holding our white colleagues and partners in this effort accountable for having truly realized the importance of cultural competency and understanding effective ways of communicating with patients, and having the patients to meet people where they are on their own level and have authentic conversations with them. I think the accountability in terms of cultural competency is key, and that entails really folks stopping and getting the appropriate training to be skilled in that regard.
Okay, Dr. Williams, I definitely agree with you there. There's a question that says transplant centers require patients to be able to care for their organ after transplant. They need to have social support to care for the graft so it isn't lost. And they want to know, how do we, I feel that as a transplant center or something, we turn down a lot of minorities because this doesn't exist. How do we get past that? And then that's going to be our wrap-up question because of time.
I think that's a matter of having the appropriate social supports. I think that some of that support actually can come from transplant centers. It does not necessarily, it's not necessarily the case that patients can't care for their organs because of the, for example, structure of their families or households. I think if we have, for example, navigators, social workers who they can come to, who can plug in as very valuable resources in the community. These are folks who can help support not only pre-transplant identification and evaluation, and then actual acceptance for a listing for transplant, and then realizing a first transplant, but they can also support these communities post-operatively. And so I think there are systems of care that need to be re-engineered to provide supports in the community. And I don't think it's that hard. I think it's a matter of allocation of resources, and I think that has not been a priority heretofore.
Okay, once again, thank you, Dr. Williams. We extend our thanks to you for being with us here today for this exciting discussion. And to kick off our next session, I am pleased to turn it over to another member of our Summit Planning Committee, Dr. Matthew Kirshen.
Thank you very much, Ramonia. And hello, everyone. My name's Matt Kirshen, and I'm a pediatric neurointensivist at the Children's Hospital of Philadelphia, and going to be moderating our next session on rationales to revise the UDDA, the clinical, legal, and ethical perspectives. Before we continue, we want to extend our thanks to our event sponsor, Transplant Connect. Transplant Connect's award-winning secure eye transplant donation and transplantation system enables 75% of all deceased organ donations in the United States and is used at more than 100 donation and transplantation agencies all over the world. For more information, visit transplantconnect.com. In our next session, we're going to evaluate potential revisions being made to the Uniform Determination of Death Act, or UDDA, and the implications that it may have on the organ donation process. As we begin, please take a second to answer the polling question that you see on your screen in the Day 2 live stream session window. The question asks, do you think that revisions to the UDDA are needed? With a yes/no response. While everyone is taking a moment to answer that question, it's my honor to introduce our panel of speakers. First, we're pleased to be joined by Dr. Ariane Lewis, who's the Director of Neurocritical Care at NYU Langone Medical Center. Dr. Lewis is joined by Thaddeus Pope, law professor at Mitchell Hamline School of Law in St. Paul, Minnesota. And our third panelist is Beth Sivertsen, who's a medical ethicist for Grady Memorial Hospital in Atlanta. We will be getting our poll results shortly, and we'll compile those and share them with you at the end of the session. Dr. Lewis, let's go ahead and begin with you. Thank you for being here.
Thank you so much. So today I'm going to be presenting on the rationales to revise the UDDA, the physician's perspective. I announced my disclosures yesterday, so I won't review those again. So as a review in terms of what the UDDA states, the UDDA says an individual who has sustained either irreversible cessation of circulatory and respiratory functions or irreversible cessation of all functions of the entire brain, including the brain stem, is dead. A determination of death must be made in accordance with accepted medical standards. The UDDA was first written in 1981 by the President's Commission for the Study of Ethical Problems in Medicine and Biomedical and Behavioral Research. The UDDA has been accepted throughout the United States as the description for the declaration of death, though I will note that each individual state in some cases has variations of this language, and in other cases has accepted death by neurologic criteria based on judicial standards, not based on endorsement of the UDDA. So the UDDA was a federally recommended statute. However, there have been a number of objections in the past few years to the use of neurologic criteria to declare death, despite the fact that the UDDA accepts death by neurologic criteria as legal death. There's lots of reasons why these types of objections occur, the most common of which is religious beliefs. But other reasons for objections to the use of neurologic criteria to declare death is the belief that recovery of neurologic function is possible, lack of acceptance that death can occur when the heart is beating, and lack of acceptance that spinal reflexes are not purposeful movements. The World Brain Death Project examined the declaration of death by neurologic criteria perspectives by different religions and found that there was no religion that universally disagreed with the concept of death by neurologic criteria. Though within each individual religion, there's varying perspectives amongst religious leaders and also members who practice each individual religion. In a survey of hospital chaplains in the United States, we found that there were objections to the use of neurologic criteria to declare death from constituents of a number of different religions. As you can see here, this was most common amongst members of the Christian faith. However, objections also occurred amongst members of the Jewish, Muslim, and Eastern religion faiths. And taking into consideration the fact that Christianity is the most popular religion in the United States, the proportion of individuals objecting from the Jewish, Muslim, and Eastern religions was higher than that from the Christian faith. Additionally, in a survey of Jewish rabbis, it was found that 78% of rabbis believed that brain death is death. There was a significant relationship between denomination and belief that a person who is brain dead can recover, belief a person who is brain dead is dead, and belief mechanical ventilation should be continued after brain death. In a separate survey of allied Muslim healthcare professionals, it was found that 84% believed that brain death is death. Half of the respondents believed families should be able to choose whether an evaluation for brain death is performed, and whether families should be able to choose whether organ support is discontinued after declaration of brain death. So with this background in mind, there are two questions that arise. First, is consent needed prior to determination of brain death? And second, how should physicians handle objections to determination of brain death or discontinuation of organ support after declaration of brain death? I remind you, this is the language that's employed in the UDDA, and unfortunately, the UDDA does not address either of these two issues at present. And so physicians have no legal support in order to be able to determine how to handle these types of objections from the UDDA. However, some individual states do provide guidance about how to handle these issues. 4 states provide legal guidance about the need for consent prior to brain death evaluation. In Montana, there's judicial precedent that consent is required. In Nevada, the law states that determination of death is a clinical decision that does not require the consent of a person's authorized representative or the family member with the authority to consent or withhold consent. In New York, the law specifically states consent need not be obtained. And in Virginia, there's judicial precedent that consent is not required. Additionally, there are laws throughout the country in 4 states that provide information as to how to manage religious objections to the use of neurologic criteria to declare death. In California and New York, the law indicates that it's necessary to make reasonable accommodation to objections to the use of neurologic criteria to declare death based on religious beliefs. Similarly, in Illinois, the law states that it's necessary to take religious beliefs into consideration when determining time of death. Obviously, these 3 states offer some guidance, and yet the guidance is a little bit vague. In New Jersey, however, the law is a little bit more concrete and indicates that if a family objects to the use of neurologic criteria to declare death based on religious beliefs, then death should only be declared based on the use of cardiopulmonary criteria. How often do these types of objections actually occur? In a survey of pediatric neurologists and intensivists, we found that 61% had encountered an objection to the use of neurologic criteria to declare death or discontinuation of organ support after brain death determination. Similarly, 47% of adult neurologists have encountered this type of situation. When asked whether consent should be required to perform a brain death evaluation, 72% of surveyed pediatric neurologists and intensivists said no, and 78% of surveyed adult neurologists said no. When asked whether accommodation to religious objections to the use of neurologic criteria to declare death should be incorporated into the legal definition of death everywhere, 16% of adult neurologists agreed with this concept, and 13% of pediatric neurologists and intensivists agreed with this concept. A few years ago, Bob Trug and I argued whether or not it was necessary to provide consent prior to declaration of brain death in CHEST. I noted that in terms of the reasons to not require consent prior to declaration of brain death included the following. First, all forms of death should be treated the same. We don't require informed consent for declaration of death by cardiopulmonary criteria, so it would be unethical to require it for declaration of death by neurologic criteria. Second, a determination of death should not represent a choice. Families should not be allowed to decide whether or not an assessment for determination of death can be performed. And then third, it's not standard practice to obtain consent before a brain death evaluation. As I mentioned earlier, the majority of neurologists surveyed indicated they do not obtain consent prior to declaration of brain death. Bob Trug argued that consent should be required to perform a brain death evaluation. He believed that consent should be obtained for all procedures and brain death determination should be considered a procedure, so consent should be required. He also noted a person does not benefit from declaration of brain death and felt that consent should therefore be required. He also commented that there were risks associated with apnea testing, including hemodynamic instability, attention pneumothorax, pneumomediastinum, cardiac arrhythmias, and cardiac arrest, and also suggested that raising the PaCO2 had the potential to cause brain damage if a patient was not brain dead prior to the declaration process and the apnea test. Lastly, he noted that persons of all religions and cultures should be treated with respect, and if a person does not believe brain death is death, their beliefs should not be ignored. In terms of the continuation of organ support in complicated brain death cases after objections are made when brain death has been determined, the most common argument in terms of why to continue support is simply the desire to avoid conflict. Other arguments include the fact that in America, we value autonomy, individualism, privacy, and religious freedom. A patient should be seen as, a patient's family should be seen as an extension of the patient themselves. Ethics and compassion dictate respect for families. And in some cases, practitioners will want to continue support, feeling that a delay in discontinuation of support will allow the family to come to terms with the patient's death and hopefully come to terms and then change their mind. Some also feel that cardiopulmonary arrest may be imminent after declaration of brain death, and so that's a good reason to continue support in this setting. However, there are also arguments against continuing organ support in these types of cases. First, hospitals are facilities for the living to maintain necessary medical care, not for the death to be maintained. Ongoing treatment after death could be seen as a violation of bodily integrity and abuse of a corpse. And there's an ethical hazard associated with allowing a negotiated standard for determining death. Patients who are determined dead by cardiopulmonary criteria should be treated the same as patients who are declared dead by neurologic criteria. In surveying neurologists about their most recent experience and how they handled requests to continue organ support after declaration of death by neurologic criteria, we found that nobody discontinued organ support without the family's consent. Management in these types of cases varied, and in some cases, support was ultimately discontinued when the family agreed to do so. Support was continued for a set amount of time. Support was continued indefinitely, or a different means was taken to approach this situation. These types of cases have a significant effect on families, healthcare professionals, and society. For families, these types of cases can lead to increased risk of complicated grief and also confusion about the patient's status. In terms of healthcare professionals, they can develop moral distress and have a weakened sense of the therapeutic alliance between the staff and the family in these settings of these objections. And in terms of society, there can be issues related to resource allocation, in which time and energy of healthcare professionals, medical equipment and beds, and medications are allocated to patients who are brain dead or believed to be brain dead in lieu of patients who are alive. Feedback from physicians and both the pediatric intensivists and neurologists and the adult neurologists who completed these surveys noted that legal guidance is needed for both physicians and the public about how to handle these types of objections. The legal guidance should address management of objections prior to brain death evaluation or discontinuation of organ support, the specific scenarios in which physicians should or can continue organ support, and the time frame for continuation of organ support. As a result of the findings of these surveys and of a number of highly publicized lawsuits that I noted earlier, the American Academy of Neurology organized a summit that was an interdisciplinary group to address contemporary concerns about brain death determination. One of the findings of this summit was the need to advocate for a consistent legal approach to brain death determination in every state throughout the country. A product of this was this publication, which addressed the need to revise the Uniform Determination of Death Act. 4 questions emerged as to why this was necessary. The first, which we've addressed in this presentation, is should consent be required to perform an evaluation for brain death? And the second, which I've spoken about today as well, is how should religious objections to the use of neurologic criteria to declare death be handled? Professor Pope will be addressing the latter 2 questions, which is what is meant by all functions of the entire brain and what are the accepted medical standards. Following this publication of these rationales to revise the Uniform Determination of Death Act, the Uniform Law Commission convened a committee to address the question of whether or not the UDDA should be revised. The UDDA committee subsequently determined that it was appropriate to proceed with formulation of a drafting committee to revise the UDDA. This was voted by the ULC Executives Committee unanimously, 11-0, that it was appropriate to proceed with the formation of a drafting committee. As a result, this drafting committee will be formed earlier this fall to begin to discuss the specifics related to revisions to the UDDA. Thank you very much, Jared, for your attention. I turn the mic over now to Professor Pope, who will be telling you about the legal rationales associated with revisions to the UDDA.
All right, thank you. So I have nothing to disclose. And as Dr. Lewis said, she talked about the consent question and the religious objection question, and I'm going to talk about the two other questions that were raised as reasons to amend the UDDA: what is meant by all functions of the entire brain, and what are the accepted medical standards for determining brain death. So last year in 2020, about 75% of deceased donation was from donors determined dead on brain death criteria, right? 9,400 out of 12,600 donors. This year, that's dropping a little bit, so it's projecting toward just 70% so far this year, 4,900 out of 6,900 donors, but 70% is still a big number, right? Brain death remains a keystone of the organ donation and transplantation system. But with respect to individuals determined brain dead, increasingly people are asking, are they legally dead? Are we complying with the dead donor rule? There's a growing amount of uncertainty, and as Dr. Lewis painted, a growing amount of conflict. And that is potentially eroding public trust. In fact, we see more people filling out cards like this: refusal to be an organ donor card. So for the last 10 years, we've had more deceased donors each year than the year before. We certainly don't want that trend to stop, and we definitely don't want that trend to reverse, where we have fewer deceased donors than the year before. So here's my roadmap for the next 12 minutes in just 3 parts. First, just to recap the UDDA, talk about this first problem, which is a mismatch between the legal criteria and the medical standards. And then second, to talk about the variability of the medical standards that are used to determine brain death from hospital to hospital across the country. So the UDDA, and I know Dr. Lewis already mentioned this, but the language is important. So again, the UDDA is the law in almost every state. And it says that in accordance with accepted medical standards, there are 2 ways to determine death: by the irreversible cessation of circulatory and respiratory functions, or by the irreversible cessation of all functions of the entire brain. The first problem is this: clinicians don't assess what the UDDA requires. There's a mismatch between the law and medicine. So again, the UDDA says there has to be irreversible cessation of all the functions of the entire brain. But brain dead people still do stuff, right? We know that brain dead pregnant women can still gestate a fetus and do gestate a fetus. The work of Allan shows that after the determination of brain death, those individuals can heal wounds, fight infections, mount a stress response, grow, sexually mature, and regulate their own temperature. It appears that clinicians assess the cessation of only some functions of part of the brain. But the law, the UDDA, requires the cessation of all the functions of the entire brain. So there's a gap between the medical criteria and the legal standard. In other words, you could be determined medically dead, but not be legally dead. And to put a finer point on this point, the American Academy of Neurology issued a position statement 2 years ago, this position statement, and in this statement, they said that a patient can satisfy brain death guidelines, so they're dead, yet, quote, neuroendocrine function may still be present. So what the AN makes the same point again in the position statement. In other words, clinicians may determine brain death despite ongoing function of the hypothalamus. And they say that that's not inconsistent with the whole brain standard of death, except that it probably is inconsistent with the whole brain standard of death. The UDDA, again, says there has to be irreversible cessation of all functions of the entire brain. And the hypothalamus is part of the brain. So, and there was a survey, and there's actually other surveys just like this, but I'll just give you this one. This was a survey earlier this year where they asked 200 clinicians at the Mayo Clinic, do you agree with the following statement, right? That a positive result upon performing the AAN protocol demonstrates loss of all functions of the entire brain. And a significant fraction of the Mayo Clinic clinicians says, no, we don't agree with that statement. Why? Because we think that there's a divergence between what the AAN is measuring and what the UDDA requires. So the medical criteria don't require cessation of all functions. Maybe it requires the cessation of all the important functions, all the critical functions. That's fair. But that effectively is the AAN or the medical community as a whole moving the goalposts on what constitutes death. And they lack the authority to do that. Let me give you an analogy. So every state where you guys are, right, your legislature has set speed limits for your roads and highways. Often it's 55 miles per hour. Well, they set that standard. The job of the police is only to measure whether or not this car or that car is going above or below 55 miles per hour. It's not the job of the police to come up with what they think the speed limit on the road should be. It's only to measure whether or not that standard is satisfied. Similarly, the UDDA sets the standard, and the job of clinicians is only to measure whether or not for this patient or for that patient, the standard is satisfied, not to come up with what they think brain death ought to be. Now, we can contrast this with, for example, Prince Edward Island in Canada. There, in Prince Edward Island, the law says death includes brain death. That's all it says. That leaves a lot of discretion to those Canadian clinicians to figure out what is brain death, how should we measure brain death, and so forth. In contrast, here in the United States, the UDDA gives a lot less discretion to clinicians, right? The UDDA is a lot more specific. Right? It says it has to be all functions. It has to be the entire brain. There has to be cessation, and that cessation has to be irreversible. So U.S. clinicians have a lot less space than those Canadian clinicians do. So we have this medical legal mismatch. And now you might say, well, big deal. Who cares, right? Well, there have been, as Dr. Lewis mentioned, a growing number of legal challenges. Perhaps the most famous of these was the Jahai McMath case. And in that case, originally, the family was saying she's not brain dead. She doesn't satisfy the brain death criteria. So they were misapplied to her. But later, they changed the nature of their lawsuit, and they went after the AAN and the AAP guidelines themselves. And so in a filing, what they said was to the court, we want the opportunity to present evidence and expert testimony that the AAN and the AAP guidelines fail to meet the requirements of the California UDDA, right? That was what they wanted to show. Now, the opponents in that case, the hospital said, This would be an incalculable disruption if this court decides that the guidelines don't meet the UDDA criteria. And of course, it would be an incalculable disruption to declare that the guidelines don't match the law. Now that case settled, and so the court never ruled on that question, but it's still lurking out there. And it's worth noting that there are a lot of pro-life advocacy organizations that have the money and the interest in continuing to push this question. And when these things are in court, they attract a lot of media attention, right? And that casts a spotlight onto this medical legal gap. And that may erode public trust, right? Because it freaks people out to hear that they might not be dead when doctors say that they're dead, right? They feel that there's some kind of deception going on. So that's the first problem, the mismatch between the medical criteria and the legal standards. The second problem is which guidelines should clinicians use to determine brain death, right? Again, to go back to the UDDA, it says that when there's the irreversible cessation of all functions of the entire brain, that determination must be made in accordance with, quote, accepted medical standards. The problem is this: which medical standards are the accepted ones? And the reason that's challenging to answer is because there's a massive amount of variability in the standards that are deployed from hospital to hospital across the country. And this has been measured and published again and again and again in JAMA and Neurology and a lot of other good journals, right? Just look at the titles: variability of brain death policies, improving uniformity in brain death determination policies, variability of brain death determination guidelines, variability in physician practices for brain death determination. And the variation is, there's lots of variations, right? Does it need to be one physician, two physicians? Does it have to be an intensivist or a neurologist, or could it be any physician? How exactly are the tests administered? So the variabilities across various dimensions. And this all reached a front in a case in Reno involving this patient. And she suffered a catastrophic anoxic brain injury during an exploratory laparotomy. And a few days later, her clinicians determined that she met the AAN criteria for brain death. Now, her father disagreed and said, no, I don't buy that. She's not really dead. He takes this to court in Reno. He loses. Why does he lose? Because all the clinicians showed up to testify and said she meets the AAN criteria. So the judge said, well, if she meets the AAN criteria, therefore she's dead. Well, Dad doesn't accept this. He appeals this up to the Supreme Court of Nevada, where he wins. Why does he win? What does the Supreme Court of Nevada say? That court says it's irrelevant that the patient meets the AAN criteria because they're not the right criteria to be using. It's unclear that they are, quote, accepted medical standards as the law, as the UDDA requires. So this created a lot of uncertainty, because if it's not the AAN, what standards are we supposed to be using, right? So this was very disruptive to have this Supreme Court decision come out. Now the legislature steps in and fixes the problem, amends the Nevada UDDA, saying that determination of brain death must be made in accordance with applicable guidelines, and then by name mentions the AAN guidelines and the AAP guidelines by name in the text of the statute. So problem solved. New Jersey has something similar, and Oklahoma tried to pass a statute this year to do the same thing. But as of right now, you really only have those two states that have clarified that it's AAN and AAP that are the authoritative accepted medical guidelines to be using. That uncertainty issue may still exist in all the other states. And in fact, it continues to get litigated. So that's the second problem, the variability in standards. And again, that may erode public trust to see that level of variability. So we see more conflict, we see more litigation, both because there's a mismatch between the legal criteria and the medical standards, and secondly, because there's a lot of variability in the medical standards that are deployed. And we're going to see more of these cases. which is why, as Dr. Lewis mentioned, the Uniform Law Commission is moving to amend the UDDA. Why? To align the medical standards to the legal criteria and to clarify which guidelines are the accepted guidelines. If they do that and the states adopt it, that should reduce variability and it should increase certainty and trust. And we then hopefully will continue to have more deceased donation as we have for the last several years. Thank you.
All right, we can turn now to Beth.
All right. Thank you for having me. And my name is Beth Sivertsen, and I am the medical ethicist for Grady Health System in Atlanta, Georgia. I am having problems advancing. I have no financial disclosures. And in addition to what's been discussed thus far by Dr. Lewis and Thaddeus, I wanted to add consideration more from a bedside perspective as to why the UDDA should be amended to come into agreement with medical practice and provide some certainty and clarification around what brain death determination actually looks like at the bedside. Now, Dr. Lewis had reviewed reasons families object to determination of death by neurologic criteria, which included religious beliefs and a belief that recovery of neurologic function may still be possible in that they can see their loved one in bed that may have reflexes and may have bodily functions that do not look like death. But I wanted to add to consideration one more factor that I have witnessed in practice as far as families rejecting the determination of brain death, and that is a very definite distrust in the concept of brain death. And like Thaddeus had said, there's this belief that these families' loved ones may not be in fact dead when doctors say they are, and the visible debate about the legitimacy of brain death that's taking place in the public forum is generating much more distrust in this realm of medicine. And certainly this is going on in other parts of the public forum, including around vaccinations and the COVID pandemic in general. I do want to back up and give you some context as to where I am coming from when I talk about my practice. Grady Memorial Hospital is Atlanta's safety net hospital. It is the 5th largest public hospital in the US. We do have 2 medical school affiliations with Emory and Morehouse. We have one of the busiest level 1 trauma centers in the Southeast, treating more than 1,000 gunshot victims last year, as well as one of the nation's leading stroke centers. Grady serves a largely Black population, and going back over time, it's remarkable how consistent our demographic is made up of 74 to 76% of Black African-American patients. This is significant because Grady has race and racism embedded in its history. Medical students were not allowed to treat white patients until 1931. And older patients will still refer to our hospital as the Gradys, referring back to the day when the Black wards and the white wards were separated by hallways. And this is significant in my review of data in preparing for this presentation. I recognized that we have seen a drop-off in our OPO donors of African-American demographics. This certainly isn't enough data to draw, very precise conclusions from. I have a lot more data that I am seeking access to more thoughtfully consider this, but we have seen a drastic decrease in the racial makeup of our donors, as opposed to the very, like I said, consistent makeup of our patient population, with African American donors seeing a decrease from 62% to 40% this year in the first 6 months. Now, to address some of the questions that came up in Dr. Lewis and Thaddeus's presentations, we do have a brain death policy. We have established in consistent with Georgia law that consent is not required for performing a brain death exam. Once a patient has been declared brain dead, clinicians allow a reasonable amount of time, up to 24 hours, to allow for the family to visit prior to removal from the ventilator. And in the event that there is lack of acceptance by the family based on neurologic criteria, objections or religious objections, an ethics consult can be requested. Now, the only thing about that is up until February 2020, for a whole year, we went without an ethicist. The ethics committee had limited bandwidth to take ethics consults. And until I was hired in 2020, really the only way to address these objections were rooted to legal and asking legal's advice as to what to do. Now, I love legal. I work very closely with my friends in our legal department, but in this situation, it's very hard to look to legal as the answer to this kind of situation, as they point to our policy. Up to 24 hours is reasonable per clinical judgment. The family may seek a second opinion at their expense, and at 24 hours, we can remove the patient from organ support unless there is a court order provided. Now, you talk about conflict at the end of someone's life, and this is a prime way to set up a situation for conflict. I have been involved with one forced removal of organ support over a family's objection, and it is very contentious, and no one feels good about it. And so just because our policy and the law may support the feeling that we can do this, it does not mean that we should. And this is where it was so important for ethics to get involved in the approach to these clinical cases. I wanted to go back and talk about Jahai McMath, who Thaddeus reviewed. She was declared dead in California in 2013 after suffering a noxious brain injury, but lived in New Jersey until 2018 when she was declared dead due to associated complications with liver failure. And one significant quote that came out of this case is that Jahai's mother found a discrepancy between what she saw and what she was being told. And one clinician reportedly told her, "What is it you don't understand? She's dead, dead, dead." And this brings me to my point in all this, in recognizing that clinicians need to provide a bit of humility in approaching these cases, recognizing that the universal concept of brain death as being death is not entirely accepted by the global or by the US population. Brain death may be seen, and I echo my mentor Bob Trug's publicized thoughts about this, but it's a beneficent legal fiction created to reflect a societal agreement that no one would really consent to live in a state of what is otherwise irreversible apneic unconsciousness. Medical consciousness and humility are required to meet the family where they are in their understanding and suffering. And so it's really pivotal that in addressing these cases, we move preemptively to help families understand what brain death means and really associate this determination with goals of care for their loved one versus forcing on the family a determination that they might not be prepared emotionally or mentally to handle. I got here at Grady in 2020, and since then I have been consulted for 4 cases for anticipated or actual brain death refusal. 2 were late consults, and like I said, these amounted to a great level of conflict with the family and forced removal of ventilation. 2 earlier consults where potential conflict was acknowledged and addressed early on, resulted in much less conflict, and frankly, the family coping with the determinant of brain death in a much more satisfying and good way. Other ethics consults I've seen related to brain death include unidentified patients progressing to brain death, and questions as far as removing organ support from patients without identified next of kin to be alerted to the fact that they have been declared brain dead. Now, I won't say that my case number 4 is enough to draw conclusions upon, but I will say that in none of these cases, religion was immediately cited as the issue. It was all distrust in the fact that the patient had, in fact, been declared dead. And disbelief in the concept of neurological death and that recovery was not possible was only cited in one of these cases. Now, what was actually cited was the distrust of the medical system, families claiming that we had tested their loved one too soon and that we just want his organs. And these are very, very hard statements to address in a very tense and conflicting setting. Distrust of the medical system due to historical racial injustice and ongoing inequities in healthcare is very much alive and being seen right now in Grady as well as other parts of the US, especially in the recent political climate of racial injustices being seen throughout the pandemic and going back. We also have to address that there are continued structural inequities in the care that we provide at Grady. Grady is a stroke and trauma center where we have a large population of potential donor candidates, and then we are not a transplant center. Our population we serve is indigent and uninsured, and a lot of this population would not be considered to be potential recipients due to the fact that they suffer socioeconomic injustices and are unable to care for organs in our eyes. And I would leave you with this idea. While Grady has seen increasing cases of brain death resistance, this is improving with preemptive measures of early family meetings and clinical transparency. I have been working with our brain death committee in order to revise our policies to make sure that ethics is involved even at the very hint of conflict arising around the brain death determination, as opposed to only being called in when that conflict has arisen and heels are dug in, and less damage control and more preemptive communication. And I'll end with this quote from Jahi's mother: "If her brain is jelly, we're going to have to accept that. I don't think people should live that way. If they're gone, they're gone." And in other words, had Jahi's family been treated honestly and with respect at the beginning, it's not clear that the family would have objected to the diagnosis of brain death. And I think this is very significant. I think my job would be made much easier, and I'd get called less if we were able to foster better communication and transparency with families instead of forcing a determination of brain death on them. We need to help them understand what it is, in fact, that we're measuring and the effects of this determination on their life and the goals of care for their loved one, as opposed to making the determination without their involvement. And I'll say thank you, and just I'll reply to Thaddeus's question to me during Q&A, I guess.
Thank you very much, Ariane, Thaddeus, and Beth. We appreciate you sharing your expertise with us. We've got about 15 or 20 minutes for what I hope will be a very insightful panel discussion. Please put your questions into the chat so that we can address them and have the panelists talk about these various issues in greater depth. What I'd also like is for everybody to, after we've heard our panel talk, answer the same poll question again. Do you think that revisions to the UDDA are needed? And so please look in your poll panel in order to be able to answer that question, and then we will share those results at the end. And I am going to start out here with the first question, and this can sort of go to the whole panel, and maybe Thaddeus, you can take the first stab at this. So we talk about fixing the UDDA and that it's going to reduce variability, right? There have been numerous studies, as you pointed out there, that there are variability in pediatric protocols and adult brain death protocols. But we also brought up the pro-life or right to life lobby, and the UDDA is just a model statute that then each one of the various states needs to enact. And so right now, a majority of the states use the UDDA or a very similar version of it. And I'm curious, if we open up this Pandora's box and if we have new guidance with respect to wording for the UDDA, similar to what we've seen, right, in a lot of the abortion legislation that's now coming out, even with the Texas rulings in the past couple of days, might we even get more variability between states than we have right now?
So that's a great question. Just as a recap for people, it's a model statute. So and it's going to take them 2 years, right? So the drafting committee will work for 2 years. In July 2023, they'll come out with this is what we think all 56 jurisdictions in the United States should adopt. Will they adopt it? Okay, and secondly, will they adopt it without amendments? Yeah, it's not going to be 56 out of 56, right? You're not going to get 100% adoption rate, and it's not going to be 100% adoption without amendments, because this is a politically charged issue, as you just indicated. But if you get 30 states to adopt it as is, right, that's going to be better than we have now, right? So it's not going to be perfect, but it might be a net improvement. And then secondly, it is worth noting that the UDDA is only one path, right? The Joint Commission or CMS could specify into hospital accreditation standards that your brain death policies and procedures need to align with the AAN, right? So it doesn't need to be in the state statute. There are other regulatory tools to get hospitals into a higher level of uniformity than they are right now.
Thank you very much. Ariane, did you want to add a comment?
Yeah, I agree certainly with what Thad put out there. I think that in order to improve uniformity, there's multiple pathways to do so, and this has to be done via multiple pathways. As I mentioned yesterday, in terms of the guidelines or the medical standards for brain death determination in the U.S., that is now being worked on to revise to create a singular guideline for the lifespan rather than having two separate guidelines. Additionally, as Thaddeus brought up, it would be very helpful to have the Joint Commission regulate the guidelines that individual hospitals use to decrease the variability from hospital to hospital, but more importantly, to decrease the variability in standards between hospitals and what the American Academy of Neurology has put forth. And that's certainly something that can be regulated, but has not been as of yet. And we're hoping to advocate for that once we've got the new standards created. On the legal front, I agree that there certainly is going to be the potential that there will continue to be some extent of variability from state to state, but hopefully with modifications to the UDDA, we'll move in a positive direction, and some of the problems that we pointed out with the UDDA will be remedied, and that there will be a number of states that are going to take on the revised UDDA, recognizing all of the issues that we've pointed out with the original UDDA, and create their new version of the UDDA on their own, such that there will be uniformity, and the uniformity will address the issues that have already been emerged from the prior UDDA.
Ariane, let me ask you a follow-up question to that we've been talking a lot about the revisions to the UDDA. Is it possible to flip the argument and say the UDDA is actually reasonable and concise the way it is, and maybe it's the guidelines that need to change? And right now, most of us feel like the guidelines represent the intent of the UDDA, But as Thaddeus pointed out, right, neuroendocrine function and other functions of the brain, right, are not currently encompassed in all functions of the brain. Do the guidelines need to take a different approach and try to look at all functions? Should some sort of ancillary testing be mandatory? Should we look at something beyond just the clinical functions of the brain and brainstem reflexes in order to try to bridge that gap?
So I think that these are definitely questions that have emerged, particularly over the past few years, but even since further back when brain death was first introduced in the 1960s. With respect to the issue of neuroendocrine function, opponents of the concept of death by neurologic criteria or of the current medical standards for death by neurological criteria argue that a key problem with them is the potential for persistence of neuroendocrine functions. And note that this persistence is in direct opposition to the concept of loss of all functions of the entire brain. First, I will note that around the world, there are no protocols that actually specify the need to lose a neuroendocrine function. So it's not like the US does something differently in this regard. Throughout the world, neuroendocrine function is not incorporated in anybody's standards for death by neurologic criteria. Additionally, there's already been many studies looking at whether or not there is persistence of neuroendocrine function and how often there is persistence of neuroendocrine function after death by neurologic criteria. And there's a wide variation in terms of how often that occurs, as little in some cases as 10%, but as much as 90% in some series. Would it be feasible to revise the American Academy of Neurology guidelines with the current medical standards to incorporate the need to lose neuroendocrine function? Of course, that would be feasible. The guidelines are set by man, so we're certainly capable of creating those standards to be different. However, that would be a dramatic turn given the fact that over the past 50 years, that has not been required, and that's not required anywhere else in the US. And moreover, I think if that change were to take place, there would have to be a strong rationale for why to do so. Meaning, is there something that's happened whereby when we see that there's persistence of neuroendocrine function, something changes that makes us no longer believe that we can use the criteria that have already existed, the standards that have already existed to define death? Because at the end of the day, the declaration of death by neurologic criteria, just as the declaration of death by cardiopulmonary criteria, is designed by humans. It's not something that we discovered. And so as a result, we create what the standards are. And so is there the potential to change them further? Of course, but there has to be a rationale to do so.
Thank you very much. I think that's a really important perspective. And I want to switch gears a little bit, Beth, and bring you back into the discussion here. And I'm wondering if you can share from your firsthand experience on the ground, what can we do to improve cultural and racial competence so that we can be proactive about addressing some of these situations rather than just be reactive and enter on the conflict resolution side? And have you partnered at all with your local OPO? And is there anything that the OPOs can do to help improve the public trust in this system and help us with cultural competency?
Thank you. And I do think there are ways to address this. We are looking to form a community ethics committee here at Grady to better recognize what objections exist with respect to brain death as well as other topics in the medical field. We would like to better inform, work with families earlier to understand not that we are forcing on them some definition of death that is not appropriate for their loved one. We need to work with these families to understand that their loved one might not want whatever result of this is, whether or not it's considered brain death. I think that's really the sticking point, is having goals of care discussions as a starting point for these discussions, as opposed to informing them that your loved one is about to undergo brain death testing, and really delineating the goals for their loved one. We are working with our OPO. Unfortunately, I don't know how much they've been involved in these discussions thus far, but we will be working with them more closely going forward to look at our policy as it undergoes revision, and trying to reduce the conflict that that arises after the fact.
Thank you so much. Thaddeus, I'm going to turn to you. There are multiple questions that have been asked by audience members dealing with some of the legal specifications of this, and I'm going to sort of put a few of them out there in the last minute or so, hoping that you can address them. So one of them has to do with whether the UDDA can define the medical standards for diagnosing death, and how those practices are regulated both at the state level and at the individual institution level, and where does CMS play into all of this in terms of how the determination of death at the state level and at the institutional level gets sort of policed, for lack of a better term.
So let me say one thing, which is, again, it's the idea of it has to be, once the statute is revised, once the UDDA is revised, that's a lot of people that are going to have their fingers in it, right? Because it's the House and the Senate in every single state, right? So it's thousands, 5,000 to 10,000 legislatures, all, so what's going to end up on the other end in 2024? It's a little bit of a gamble, but the idea is not to put the standards into the text of the statute. So the statute would not say this is the temperature, this is the blood pressure, this is the the CO2 level, right? It would only be a reference to the AAN guidelines, and also ideally to future iterations of the AAN guidelines. So the AN or any private professional association would be in control of what the guidelines are. It's just that the state law is pointing to those guidelines as opposed to any other guidelines as the authoritative ones. And this has been a state law issue. But as I said, CMS could piggyback off the state law, or they could amend the conditions of participation and say, and they could clarify in addition to the state law or instead of the state law, CMS could clarify which guidelines are the appropriate guidelines to be using to make a determination of brain death.
Ariane, just for clarification for the group, are there any other guidelines that exist? We keep talking about the AAN and the AAP guidelines as the standard of care, and currently the Nevada statute, references it. And Thaddeus talked about, future iterations of the AAN guidelines. Now, these are guidelines coming out of a society, or in this case, a joint society and expert opinion, rather than coming out of a state or federal sort of medical agency. Are there any other guidelines that exist, and should the AAN be the right home for these guidelines versus some sort of a medical board, for example?
So the publication, which I referenced a couple of times based on the interdisciplinary summit that was put together from the American Academy of Neurology a couple of years ago, was endorsed by a number of different medical societies. And in that publication, it was noted that the accepted medical standards are the American Academy of Neurology's 2010 guidance on brain death determination and the American Academy of Pediatric, Child Neurology Society, and Society of Critical Care Medicine's statement put forth in 2011. So those are currently the accepted medical standards for brain death determination throughout the US. There's not another society or anything else that's been put out there that supersedes that. However, there is institutional variability in some cases from that, as was pointed out by Professor Pope during his presentation. I'll also note relatedly, as I noted, one of the comments in the chat addressed the question as to whether the AAN supports revisions to the UDDA. The AAN does indeed support revisions to the UDDA, as did the Neurocritical Care Society, advocating for revisions as well. So this is the need to revise the UDDA is certainly being endorsed by these organizations.
Yeah, Matt, maybe if I could in 30 seconds just say, right, this is not like a mammography, right, where you have, some radiology associations saying one thing and some cancer associations saying something different. Should it be age 40? Should it be age 50? Should it be every year? Should it be every other year? Right. So that there's not a case where you have competing guidelines. There really are no other major national society with competing guidelines. It's the fact that when Dave Greer and other researchers polled, they looked at Mass General, Cleveland Clinic, Mayo Clinic, UCLA. They all had different guidelines. So the idea is not that there's another competing professional society. It's just that nobody, or not nobody, but a lot of people are not following the AAN guidelines to the letter.
Thank you guys very much. We are out of time. Before we conclude, I promised that I would share the results of our poll. So of the audience at the beginning of the presentation, 93% of respondents felt that the UDDA should be revised. And at the conclusion of our presentations, 97% felt that the UDDA should be revised. And I thank everybody, particularly our panelists, for sharing their expertise and their insight with us. And I thank members of the audience for your wonderful questions. At this point, I'd like to hand it over to my colleague on the National Donor Management Summit Planning Committee, Sandy Kirscher, who's going to moderate the next session.
Hi, Sandy, we're ready for you.
Thank you, Dr. Kirshen, and hello, everyone. My name is Sandy Kirshner, and I'm a nurse practitioner and the advanced practice provider team lead for the at Bryan Medical Center here in Lincoln, Nebraska. Our next session will examine infectious disease with a special focus on HIV and hepatitis C transplantation. Recent case studies have highlighted the success of solid organ transplantation from HIV and Hep C infected donors. We're pleased to be joined by two renowned surgeons with extensive expertise in this area. To speak on HIV transplantation, it's my pleasure to introduce Dr. Dory Segev, Professor of Surgery and Epidemiology at Johns Hopkins University. Dr. Segev will be followed by Dr. David Goldberg, Associate Professor of Medicine at the University of Miami Miller School of Medicine, to address hepatitis C transplantation. We'll begin with Dr. Segev.
Thank you for the opportunity to share with you today the story of solid organ transplantation and HIV. The story ends with the historic donation of somebody living with HIV as a living kidney donor to another recipient with HIV. The story begins as a combination of improvement in HIV care, lessons from HIV-positive recipients, inspiration from South Africa, policy research, continues on efforts on Capitol Hill, a national clinical trial, HIV and kidney research, and then just some good old-fashioned altruism. So let's start with improvement in HIV care. Part of this is a celebration of the fact that HIV is no longer a fatal disease, but is a chronic disease, and people who have HIV get other conditions as well. And it turns out that about 1.5% of individuals on dialysis are HIV positive, and there's been a 14-fold increase in prevalent dialysis cases among HIV positive people in the last 10 or 20 years, again, because people with HIV are living long and otherwise normal lives, and part of normal means getting kidney disease. It also means getting liver disease, and there's an estimate that about 1% of the liver transplant wait list in the United States is also HIV positive. It turns out if you have HIV and kidney failure, you don't do particularly well, 23% 5-year mortality versus 63% for HIV-negative counterparts. If you have HIV and end-stage liver disease, you also don't do well, with a higher mortality on the waiting list and lower access to transplantation. So Peter Stock, about 20 years ago, showed us that you can transplant recipients who are HIV positive safely and effectively. Their paper in the New England Journal back in 2010 showed good patient survival and graft survival for HIV-infected recipients of HIV-negative kidneys. When we followed this out for longer, Jamie Locke and I showed that the survival of an HIV-positive kidney transplant recipient equals that of HIV-negative matched controls. And there's tremendous survival benefit in people who are HIV positive for undergoing kidney transplantation. Here you see within 6 months, there's already a huge survival benefit, and out into the long term, there's a substantial survival benefit from getting transplanted. One of the challenges that Peter Stock and his group faced early on was that of rejection, with a 3- to 4-fold higher risk of rejection in HIV-positive recipients. However, this was found to be related mostly to immunosuppression choices. Here you see that those who received ATG actually had a 2.6-fold lower risk of rejection than those who were not treated with induction therapy. And it turns out that induction therapy is not associated with post-transplant infections in HIV-positive people, just like we know from HIV-negative people as well. So whatever the appropriate induction is for your recipient, it is safe to give that appropriate induction, and we've learned that lesson in the last 20 years. HIV-positive recipients have increased dramatically in the last 20 years in the United States, both on the kidney and the liver side. The numbers you're looking at here are using HIV-negative donors. Then we were inspired by Elmi Mueller in South Africa. She published in 2010 her early case series of kidney transplants from HIV-positive donors into HIV-positive recipients with tremendously good outcomes, inspiring all of us to think about this possibility in our own countries. Of course, South Africa is quite different from the United States in terms of the HIV landscape, with a much lower prevalence, but a much higher incidence of transmitted drug resistance in the US. So the challenges we would have in the US would be quite different from those that Elmi faced in South Africa. One of the biggest challenges was that it was illegal to transplant organs from HIV-positive donors. This was put into congressional law in the 1980s through the National Organ Transplant Act. So it would take an act of Congress, quite literally, for us to be doing HIV to HIV transplants in the United States. And here you see, with 7,000 bills introduced before Congress every year, and so few of them becoming law, that achieving an act of Congress is not an easy thing. So hence policy research and the contributions of Brian Boyarsky, who had just finished his undergraduate training at Johns Hopkins and came to our lab to work on a policy project. If you want to convince Congress to do things, you need to convince legislative assistants working in congressional offices that there will be benefit, lives will be saved, it won't cost too much money, and their own particular constituents will be benefited and not harmed by the thing that they're going to sign on to. Brian did some early work published in AJT to try to estimate how many donors there might be in the United States who are HIV positive, who we were throwing away their organs right now, how many lives would be saved as a result, and how much money Medicare would save. Because one big advantage of doing policy in kidney transplantation in the United States is that when we do a kidney transplant, we actually save Medicare money, because otherwise they have to pay for dialysis. This got some traction above the fold on the front page of the New York Times, with the quotation of the day encouraging Congress to pass a bill to allow the use of HIV-positive organs for transplantation. So then we took this to Capitol Hill. This is Representative Lois Capps, who helped us champion the HOPE Act. We talked to Congress, we talked to the Obama administration, including the people working on the National HIV/AIDS strategy, as well as professional groups to endorse these efforts. This is the timeline. This is considered a rapidly accelerated timeline. For example, the immuno bill that just passed took more than 10 years to get passed. We were able to pass this bill in less than 3 years. But you see here sort of how the timeline unfolded on the Hill. While we were talking to people in the Senate and in the House of Representatives, we talked to policy experts from many national organizations. We got a lot of positive press on the research we were doing. We met with Health and Human Services, the director of the AIDS office at the White House, and got a lot of support from all these groups. These are the official endorsements that we got from various groups that were medical and patient-oriented groups and HIV-oriented groups, et cetera. We had a congressional briefing in June 2012, well before the bill was introduced, led by Congresswoman Lois Capps, who had been a former nurse, so she could speak to the medical aspect of it. We had an ABC journalist who was well known on the Hill, and as a result, more than 100 legislative aides showed up to our briefing, standing room only. We introduced all the facts of the case, as well as had some transplant recipients speak about their personal experiences, which was quite emotional for the legislative aides who showed up. These were the people supporting it in the center. As you see, it was across both sides of the aisle, bicameral and bipartisan. These were the supporters in the House as well, again, on both sides of the aisle, with Lois Capps as our House leader. It was introduced in February 2013 as the HIV Organ Policy Equity Act, or the HOPE Act, went through the Senate Help Committee quite quickly and approved on the Senate floor, went to the House, stalled a little bit in the House. Our friends from the White House helped talk to the folks on the E&C committee, get it out of committee, and then it was approved in the House on suspension, and President Obama signed it in November. 2 years later, HHS published the research criteria which were necessary to actually implement the HOPE Act. It took them 2 years because we put in a 2-year requirement into the bill. Otherwise, who knows how long it would have taken them. And then it took some time for these changes to make their way through the regulations and policies in the United States. And by 2016, we were actually able to do HIV to HIV positive transplants. And that happened in March of 2016, and we did the first HIV to HIV kidney and liver transplants at Hopkins, and we got a really nice note from President Obama, who had remembered signing the HOPE Act into law because, as he said in the White House, he didn't get to sign very many bills into law those years, and he was very happy to see this actually take clinical place. We then formed a national clinical trial. This is Christine Durand, my person who started as a mentee and is now a colleague and even at times a mentor in infectious diseases, who has been my partner in running this national trial. At first, we got funding from the NIH to understand HIV positive donors. And then a planning grant to plan a multi-center effort, and then 2 multi-million-dollar UO1 multi-center collaborative trials to study HIV to HIV kidney and liver transplants across the country. We've had 33 centers participate on the kidney side and 20 on the liver side, and here you see those centers that are involved in this national multi-center effort. In general, basically, we enroll people who are HIV positive kidney or liver candidates, and then they get offers. And if they get HIV negative offers and they take it, they go into the HIV negative donor arm. And if they get an HIV positive offer and they take it, they go into the HIV positive arm. And we compare the two arms in terms of patient survival, graft loss, rejection, HIV breakthroughs, opportunistic infections, et cetera. And you see here the inclusion criteria for the candidates as well as the donors, which are pretty minimal exclusions. It turns out we're also able to use false positive donors, which in the past we had to discard because if we were wrong about them being false positive, then we were accidentally transplanting an HIV positive organ. Today, if there's a false positive, it still goes through the HOPE Act into somebody who's HIV positive. And then if it turns out that we were wrong, we have not exposed somebody unnecessarily to HIV. And this has grown as well as the HIV positive donor practice. We've gotten more and more engagement from organ procurement organizations. At first, there were very few that were comfortable dealing with HIV positive donors, but we've done a lot of education, a lot of outreach, a lot of talking to OPOs, and our engagement has grown dramatically. And as a result, the donors available to people who are HIV positive have grown dramatically as well. There is a strong willingness among people living with HIV to accept HIV positive donors, and that has led to a great engagement in our HIV to HIV trial. We were able to publish the first report of this last year in AJT on the kidney side of things. Graft survival in those who received HIV positive organs was equivalent to those who received HIV negative organs, which was great. Rejection-free survival was a bit similar, although there was a slight trend to a higher risk of rejection in those who received HIV positive organs. However, this was quite confounded by the use of depleting versus non-depleting induction. Remember, I showed you data at the beginning that those who get depleting induction have much lower rejection rates. It turns out that is the same for those receiving HIV positive organs in our trial. Those who got depleting induction had half to 1/3 the risk of rejection as those who did not, who got non-depleting induction, and as a result, it may be that this confounds the finding that we had for rejection, but time will tell. We've also studied superinfection. So our colleagues in the HIV virology lab studied 22 of our recipients, including one who had an HIV breakthrough, and they did next generation sequencing to see if there was any evidence of donor-derived HIV infection strains in the recipient, and there was no evidence of superinfection, which was very interesting. The HIV breakthrough was actually recipient HIV breakthrough, not donor strains of HIV breakthrough. And so this gives us some pretty good reassurance that if somebody is on antiretroviral therapy successfully and they get an HIV positive donor, they don't now see a new strain of HIV infecting them. We then took the research the next step to understand if it was possible in any way for there to be HIV positive living donors. This is Abby Muzali who did some of this work. Obviously, there were concerns because in the past, living with HIV meant also the risk of HIV-associated nephropathy and kidney disease. So we wanted to determine the ESRD risk in modern people living with HIV with modern antiretroviral therapy, stratified by CD4 and viral load. We studied 40,000 people in a cohort of people living with HIV and compared them to 16,000 people from the NHANES cohort who was HIV negative. We looked at the impact of CD4 count as well as the impact of viral load, as well as the impact of the other traditional features that are risk predictors in living donors. And it turns out that if you fit certain donor characteristics, there are many people living with HIV who would be perfectly safe to be living kidney donors. And then some good old-fashioned altruism. This is a study from a clinic in Baltimore of people living with HIV showing a high willingness to donate organs as a deceased donor as well as a living donor, much higher willingness than in the HIV negative population. And this is work that Sarah Rasmussen did, looking at motivations about living donation among people with HIV, with really special motivations like solidarity with the HIV positive recipient, wanting to overcome stigma associated with HIV, giving back borrowed time, and contributing to science. When we put out the call that we had an IRB approved protocol for HIV positive living donors, several came forward, but Nina Martinez was the most enthusiastic and the best candidate for the first person in the United States ever living with HIV to be a living kidney donor. And what her desire was to lift the shroud of HIV-related stigma. And she indeed did that, showing that somebody living with HIV in 2019 at the time, was somebody who was perfectly healthy and healthy enough to donate an organ to somebody else and save their life. What is to come with HIV to HIV transplants? Hope in Action is our consortium of putting the HIV Organ Policy Equity Act to further use. There will obviously be an expansion of HIV to HIV transplantation, hopefully increased OPO engagement to increase deceased donation, better education and awareness to increase living donation, a better understanding of superinfection, better virologic studies, including studies of the latent reservoir and other aspects of HIV virology. Our virologist colleagues tell us that some of the things that we are learning from HIV to HIV transplants might actually even help HIV cure science as well. And there are directions that we will likely go that we have not even yet anticipated. So this is an exciting road, and it's exciting to share with you where we started, where we've come so far, and where we might go in the future. I would like to acknowledge our entire Hope in Action team, and in particular, Christine Durand, who's been a tremendous partner on the clinical ID side of things, as well as Aaron Tobin on the pathology and virology side, as well as all of our collaborators. And each of these collaborating centers has their own champions, and there are a tremendous number of people contributing to this work and this research. And of course, my research group, the epidemiology research group in organ transplantation, and all of the research assistants and analysts and everybody else on our team who has helped us understand this problem for the last 10 years.
Thank you for the opportunity to speak today about transplantation of organs from hepatitis C infected donors into hepatitis C negative recipients. I do have some relevant disclosures. Some of the work that I'm doing now is supported by a U01 from the NIH. I have received grant support to deal with transplantation of organs from hepatitis C infected donors. And my new disclosure is that transplantation is a personal one for me, as several people in my life have been recipients of a life-saving transplant. So the objectives of this talk are, one, to discuss the background data that led to developing trials of transplanting organs from hepatitis C infected donors into hepatitis C negative recipients. Review published data from recent studies and case series exploring the transplantation of organs from hepatitis C infected donors into hepatitis C negative recipients, and discuss barriers to making this practice standard of care. So just to make sure everyone is on the same page, when we talk about hepatitis C positivity in organ donors, it's important to look at the error that you're talking about. Prior to 2014, hepatitis C NAT, or nucleic acid testing, the most commonly being the qualitative RNA, was not mandatory and was variable. Donor hepatitis C positivity was largely defined by the hepatitis C antibody, and data using large registry studies focused solely on the antibody. This is important because we know in the general population, about 1/3 of people that were previously infected don't actually have the disease because they can spontaneously clear it, but the antibody will persist largely for life. Hepatitis C antibody positive does not mean active hepatitis C infection. Antibody, you could argue, is a red herring. It could be a false positive. It could mean that someone previously was infected and either spontaneously cleared the infection or were treated. or chronic infection with a fluctuating viral load, whereby the viral load is so low that it goes down to zero or close to zero, that it's not detected on a qualitative NAT test, although this is quite rare. So when we're talking about hepatitis C positivity in organ donors, we want to make sure everyone understands that the antibody itself does not mean increased risk transmission. All of the data published until 2014 was on antibody positive, NAT negative transmissions. Sorry, all of the data on transmissions of hepatitis C in this setting are increased risk donors that were in the window period. Some actually had hepatitis C NAT positivity on a pre-donation sample. And studies, though, using OPTN UNOS data prior to 2015 are based solely on antibody positivity. For the purposes of this talk, hepatitis C positive means hepatitis C viremic, where the donor actually has a confirmed hepatitis C infection. So there have been important changes to the donor pool that have made this an issue that really has continued to be on the forefront of transplantation. So we know that the number of organ donors in the US has increased dramatically and continues to increase, largely due to the impact of the drug opioid epidemic and now, unfortunately, to other drugs, but really due to the drug overdose epidemic. Corresponding to the increased number of donors that have active or recent drug use, we see that the number of donors with hepatitis C NAT positivity has increased, and this number has increased further in 2020 and into 2021. Now, what about the use of hepatitis C viremic organs prior to 2016? So liver, there was high utilization. This was really the most common indication for transplantation. So we had a lot of recipients that could receive these organs. They were largely untreated prior to transplant, so it was a natural fit. A large pool of recipients, as I mentioned. Kidney, there was limited utilization of hepatitis C for hepatitis C positive recipients, and there was genotype restriction. The reason being is that we know that most of the recipients were infected with genotype 1, and prior to the newer advent of therapies, genotype 2 and 3 were tougher to treat, and we wouldn't want to give a genotype 2 or 3 donor to a recipient and then leave them with an infection that was more difficult to treat. Interferon and ribavirin for the mainstays of therapy were quite challenging post-transplant and could lead to the risk of rejection, so we really shied away from using these organs. There was increased utilization in 2014 and 2015 for hepatitis C infected recipients because we were able to treat all genotypes with arguably relative ease with medications that could cure all types. Lung and heart, these organs were rarely used. Hepatitis C was considered a comorbidity in recipients, so really we would not have patients listed that have active hepatitis C. And there were data suggesting worse outcomes when the donor had hepatitis C and the recipient received a lung or a heart. So the first pilot trials of hepatitis C donor-positive recipient-negative kidney transplants used grisoprevir and elbasvir or Zepatier. Those studies were conducted at Penn, the Thinker trial, where I previously was a faculty member. And in those studies, because grisoprevir elbasvir only worked against genotype 1 and 4, we required real-time donor genotyping. This added donor complexity. Any OPO staff member on this probably will recall at least once being bothered by us to get donor blood sent to us ahead of time for genotyping. This led to organ refusals because we couldn't get a specimen or the wrong genotype. We started treatment on day 3, and all 10 people in our pilot trials were cured. We expanded this and published data on 40 recipients. 39 of 40 have cured with first-line therapy, one who actually failed first-line therapy and had to be cured with second-line therapy. The same time we were doing the study at Penn, Johns Hopkins was doing a study called the Expander trial. They were using grisoprevir and elbasvir, but they were genotyping after the fact and using sofosbuvir if the donor had genotype 2 or 3. They started treatment on call to the OR, and all 10 of theirs were cured, and 7 out of 10 never had detectable hepatitis C, with detection being checked on day 1 post-transplant. So I just want to present a selection of other published studies and going to go both above and below the diaphragm. In terms of abdominal, the Cleveland Clinic had published what they called a real-world experience of kidneys and livers. They had 64 kidney transplants, 41 were cured, 10 had end of a treatment response, and 7 were on treatment. Methodist in Tennessee did a standard of care approach where really, in essence, all patients on the waitlist were considered eligible. They reported data that 53 transplants all were cured. Now, treatment was started later, anywhere from 1 to 3 months, which might be an issue as we'll get into. Stanford, in a sort of non-trial experience, did 10 of these transplants. And again, all 10 were cured, although there was an increased signal for rejection in these recipients of livers. Now, in terms of thoracic, really Vanderbilt led the way with doing these in large studies in heart transplantations, where it was standard of care, whereby it wasn't IRB approved protocol, but there was special consent and approval from higher ups within their administration. Their initial studies were of 70 recipients of Hep C NAB positive donors. The median days from activation to transplant was 4 days. So these people were being activated, and within a week, they were almost all transplanted. Now, this was back several years ago when things have changed. Their 1-year survival was 90%, which is expected for heart transplantation, and everyone who survived to the point of getting hepatitis C cure, SVR12 sustained virologic response, was cured. Brigham and Women's had a formal trial, and interestingly, they did a 4-week course of Epclusa, where they started treatment within a few hours post-transplant. They had data on 44 patients in their initial publication. All were cured. In Toronto, they had an interesting protocol where they used ex vivo lung perfusion, and they actually did UV light to the perfusate of the fluid as they were pumping the lungs through. And what they actually found is that they could lower the viral loads, and in 2 of 11 cases, the recipients never developed hepatitis C, suggesting that you can actually prevent infection by inactivating and killing the virus prior to transplantation. There have been some novel treatment approaches sort of moving beyond the standard treatment. So there was a study published by the Toronto group where they did short course GP or Mavorite with ezetimibe, which is a cholesterol medication, but also is thought to block entry of hepatitis C into cells, where they started that. Both were started 6 to 12 hours pre-transplant, and they completed therapy in 7 days. And again, the thought was that the ezetimibe may serve to block hepatitis C entry into cells. They published data on 30 transplants across different organs. 30 out of 30 had SVR12, or all were cured. Interestingly, 2 of the patients had viremia at the end of treatment, yet still went on to be cured of their hepatitis C. The group at VCU has done a sort of very interesting adaptive therapy where they did ultra short duration. All patients receive 1 dose on call to the OR, and over time, they've adapted their approach to longer and longer therapy, but still it's ultra short. First, they did 1 dose pre and 1 day post. 3 out of 10 developed viremia and required full therapy, so they thought that was not long enough. They then went to 1 day pre and 2 days post, and again, 2 out of 15 developed viremia. And then they've expanded, and again, I said the 1 and 2 is 1 at 25. They've now expanded that to a few extra days. But interestingly, though, those who did not get sort of clearance with that short course did require full course of therapy. 3 out of 6 were cured with that first line full course of the 6. 2 failed first line and were cured with the second course. 1 failed first and second line, although in a recent publication, they did say, and I apologize for the error, that that person was eventually cured with third line therapy. And then the group at Johns Hopkins has done short course therapy for 4 weeks post kidney transplant. Of note, all of the short course therapies are when the recipient or the donor is a non-liver donor, because it's thought that these are acute infections and you can actually clear it and prevent it from infecting the liver. Whenever the liver is the organ being transplanted from a positive to a negative, always giving full course therapy. And that's sort of the standard approach. And I don't think anyone is yet willing to try short course therapy there. And I mentioned the Hopkins study, 10 out of 10 were cured. So what's the current landscape in the US? So there's variability. Some centers offer this as standard of care without IRB approval, except for data collection retrospectively. There's a variable consent process, and the plan is in these centers to apply for insurance approval afterwards. Some health systems will agree to pay if insurance declines as a backstop, because not all insurers will approve it in a timely fashion, and or have a copay that's reasonable. There's variable information provided to patients, also including potential costs and copays. There are emerging publications, though, of potential unanticipated risks. So the Methodist group had published an increased risk of BK and CMV in kidney recipients. Both Methodist and Cleveland Clinic with delayed therapy had recipients that developed fibrosing cholestatic hepatitis C, or bad hepatitis C, in a post-transplant patient. The VCU, as I mentioned, the treatment failures. Toronto, in their lung study, did actually have 2 out of 20 that relapsed and had to get retreated. The Mayo Jacksonville had someone who got a liver from hepatitis C infected donor. There was insurance delay. They got renal failure from hepatitis C related glomerulonephritis, was on dialysis, and ended up dying a year post-transplant, likely due to complications from hepatitis C. And Ohio State published an interesting study where they had significant refusals and delays of insurance to pay for the hepatitis C therapy more in their kidneys and their livers. And again, we published this in Transplantation that there's been a disturbing early pattern of disparities in utilization of kidneys from hep C viremic donors, where there's decreased use in racial and ethnic minorities, women, and those with less education. So how do we implement the practice? So I will admit I am biased, but I think there should be an IRB-approved research protocol vetted for safety and informed consent that evaluates recipients for higher risk features. Because there are unknowns, do we know the cure rates, the survival benefit risks, the CMV and BK and long-term graft outcomes? However, I'm probably in the minority there, but I think a reasonable alternative is that there needs to be some formal education and informed consent process that does not disproportionately leave out one group of patients, as we're seeing is the case right now. There should be some sort of pre-transplant assessment of liver disease, and I think you could argue what exactly that entails. There must be guaranteed drug coverage. I think that there needs to be a way to ensure that patients can get the medication with a safety net, especially because we don't want to restrict it to patients with certain insurances or people of lower socioeconomic status that can't cover the copay or have Medicaid that does not pay for it. I think we should use Epclusa or Mavorite as the treatment regimen. And I still think full course therapy, if the only real benefit of short course therapy is decreased cost, but there's risk of treatment failures, I don't think it's worth the risk. Again, as I say there. So what are some of the logistical barriers to implementing this in clinical practice? So universal insurance approval is a major barrier. So in 2017, 65% of state Medicaid programs still had fibrosis restrictions. DAAs are not FDA approved for acute hepatitis C. So technically an insurer could say this is not acute, this is acute hepatitis C, we're not going to approve it. And they technically are following the letter of the law. As I mentioned, the group from Ohio State published on denials and delays and timing of treatment initiation. So when do we do this? So we know that earlier the better. I think you would argue that waiting months increases risk, but how do we do perioperative treatment initiation? So insurance approval prior to hepatitis C infection would be ideal, but that's logistically not possible. Do you authorize the entire list? Will they approve it without documentation of hepatitis C? Does the health system eat the cost for the first few days? But what if the recipient then never detects viremia? Who's going to pay for that? And will insurance approve based on donor viremia? There's a lot of variability. So want to give a plug for the Thinker Next trial. So this is a NIH-sponsored U01 and 8-center trial. These are the 8 sites participating. 4 of the sites now are active. There's a website here. So these are 8 centers that are actively going to be looking for hepatitis C infected kidneys for our patients. Looking at key and answer questions of cure rates, outcomes compared to well-matched comparators, allograft function, survival benefit, CMV, and CKD. So the key takeaways, so transplanting organs from hepatitis C infected donors is important to save more lives, increase the number of transplants, improve utilization of a scarce resource. The DA should challenge how we rethink of hepatitis C in the setting of transplantation, but I think informed consent is critical, and we need to define the operational barriers for broader utilization, focusing on insurers, optimal patient selection, and unexpected risks. And with that, I thank you.
All right, Sandy, I think we can go to Q&A. Thanks so much, Dr. Goldberg.
Yeah, thank you, Dr. Goldberg, and thank you, Dr. Segev, for your wonderful presentations. We'll now open it up for a few minutes for questions and answers from the audience. If you have any questions for our presenters, please enter them in the Q&A feature of the Day 2 Part 1 session window. It looks like Dr. Segev is not available for questions, but if you have any for him, please go ahead and submit those, and we'll try to get those answered at a later date. But it looks like we have one right now for Dr. Goldberg at this point in time. It says, how do you optimize patient selection? And are there those patients that are more likely to benefit and those that are more likely to be harmed?
So I think we don't necessarily know the ideal patient. Now, like I said, sort of, for my full disclosure, we are doing, I'm the co-PI of a multi-center trial. So I am sort of biased in sort of how I approach this. I think we need to think of patients that can, tolerate the hepatitis C. And if you're doing this outside of a clinical trial where there may be delays in approval of the drug, can tolerate delays in approval. So, although performing a fiber scan, for example, is not realistic in real world, I think, unless you have access to one, a research one and things like that, I don't think someone who has had cirrhosis, for example, or advanced liver disease should get one of these organs unless, you could say for sure, I will start treating you on day one because of those risks of liver injury, especially if you're getting delays of therapy. We in our trials have restricted to people of older age. We've said 70 plus because there are some data that acute hepatitis C can be more aggressive in older recipients. Now, in some of these standard of care approaches, they have used donors of recipients that are 70 plus without incident. But again, I think you need to think about what are the potential delays in therapy going to be. And again, that's sort of really across the board. The other thing, though, in terms of, lung transplants, I think is the one sort of thing that could be a little bit more complicated is that none of the medications technically can be crushed and pulled down a feeding tube. And there are some concerns that if you use Grasopavir or Elbosphere, it actually may affect the absorption of medications. We have used, Maverick GP about be crushing it. We have crushed Zepitir in our lung trials that we did when I was at Penn, and there are some data about crushing Epclusa, but that's just an issue for lung recipients who may be more likely to be on the vent and require a feeding tube if you want to initiate therapy on the earlier side post-transplant.
Great. I think there's just one more question. It's is there any difference in outcomes with early versus late treatment with direct acting antivirals? And is there an optimal duration of treatment of therapy?
So there are no definitive data. I think the challenge is that most places that have done this have done one approach versus another. So to make comparisons, you're just comparing center 1 versus center 2. To do a sort of trial of that would require some complex non-inferiority design that will require a large sample size. That's, I think, largely infeasible. Now, the biggest complication that you worry about, one, there is the hepatitis C associated glomerulonephritis that you saw at Mayo Jacksonville, but that's very rare. It's really the fibrosing cholestatic hepatitis C, which is unique to transplant recipients of any organ. You can get it if they're a kidney recipient, you can get it if they're a lung recipient. If you look at the technical definition of that, you can't diagnose fibrosing cholestatic hep C until 4 weeks after transplant. So I would argue that doing it within 4 weeks is ideal. Now, again, the data are not conclusive, but the only reported cases of the fibrosing cholestatic hepatitis C were when the therapy was delayed. But again, I think the N is so small that it's tough to argue that, but I think the sooner the better, I think is the safest way of saying it.
Great. I believe that's all the questions we have right now. Our thanks again to both Dr. Segev and Dr. Goldberg for being here today. At this point, I'll turn it back to Deanna Fenton, Program Manager for the Alliance. Thanks.
Thanks so much, Sandy. At this point, we're going to transition to our talkback session with our virtual poster presenters. We hope you've all had a chance to review the recorded mini presentations on our website, and now is your opportunity to hear from them directly. To do that, you're going to exit out of this live stream, and in the Sessions tab, you'll see the interactive poster session. Click on that item, and you'll see a button that says Join Live Talkback. If you haven't already viewed their pre-recorded mini presentations, there will also be a link available to see those in the session description. Once you click Join Live Talkback, it will automatically open up a Zoom window for you. You'll have the opportunity to self-select your preferred breakout room, each of which houses a different abstract presenter. This is easy enough to do. All you do is in your meeting control panel at the very bottom of your Zoom window, click Breakout Rooms. This will display the list of open rooms. Select the room you wish to join and click Join. You can repeat this process to join other breakout rooms as often as you'd like. Should you need any assistance, a member of the Alliance team will be available to assist you. You'll be able to jump between breakout rooms to visit with different presenters until 1:40 p.m. Eastern, 10:40 a.m. Pacific. But before you close out of the session, please be sure to place your vote for top abstract submission. We'll announce the winner later this afternoon. At 1:40 p.m. Eastern, you'll exit the Zoom meeting and come back to the Day 2 live stream session in the agenda for our discussion on DCD hearts and lungs. Thank you, everyone. We'll see you back here shortly.
Being part of the Alliance for many years has been a very rewarding journey for me. Thank you and congratulations to the Alliance on 15 great years.
I want to wish the Alliance a very happy 15th anniversary. Congratulations on your success, and thank you for all you do to help all of us who do this work stay focused on the main thing, helping donors and donor families realize their final wishes and helping patients in need.
My family and I are from Nigeria. My mom is a nurse at Christiana Hospital, and my dad is a tax accountant and a college professor. My parents came here on vacation, but then I became sick. They've told me that my skin was turning pale, kind of yellow, like jaundice, and we decided to stay here so I could receive better medical care. My transplant hasn't held me back at all. I still do the same things as everyone else, and I feel like a normal person who didn't have a transplant. And I run track, and I love reading books, and on average, I can read about 3 to 4 in a week.
How does it make you feel when you see Oni running down the track?
Yes, she's a miracle. Work of God.
Transplant games are important so that we can find other people like us and just connect, where we can come together and play sports and go to different events. I come home with multiple medals every time.
What's your favorite part of the transplant game so far?
Track.
Did you win today?
I got first place.
I just like relating with people who know what it feels like to have organ donation or know someone else, because we're all like one big family. Gift of Life is a special organization because it helps people recover and helps them get the information that they need during their transplant process. Having the support of Gift of Life helps to motivate me so that I can make them proud. I want to be a pediatrician when I grow up so that I can give back to other families. Lots of wonderful doctors and nurses helped me through my time in the hospital when I was younger, so I want to be someone else's wonderful doctor. Now, getting older, thinking back to my transplant, I'm very grateful for everyone and what they've done for me. They helped save my life, and without them, I probably wouldn't be here. One thing I would want people to know about organ donation is that it's real and it works and it saves many lives and helps families. It's important to educate young people earlier about organ donation so that they can make the choice to help someone or save someone else's life. If I was to thank my donor, I would say that I'm very thankful for the precious gift that they've given me, which is a second chance at life. I feel blessed because if I didn't have my liver transplant, I wouldn't be here today. And when I think back at all the things I've gone through, it's kind of like I can't imagine my life without it. Hello, Juniata College graduates, parents, and faculty. Thank you for the opportunity to allow me to introduce a great man and my mentor, Mr. Howard Nathan. I am honored to tell you that I'm a strong girl standing before you, and I had a liver transplant at 10 months old in 2005. The new liver allows me to live a healthy and normal life thanks to the generosity of my organ family and organ donor. I am a junior at Archmere Academy, a private Catholic high school in Claymont, Delaware. Howard Nathan often says that he remembers holding me shortly after my life was saved by my liver transplant. I was only 10 months old at the time, so I don't remember being held. But I do remember just a few years later seeing Howard holding a loudspeaker to his mouth as he called out encouraging words to me, along with thousands of others who would come together for a Gift of Life event known as the Donor Dash in Philadelphia. I was walking with my parents and I was looking up. Howard seemed a towering figure and an energetic one. I knew his motivating words were meant for me and have thought a lot about them ever since. But I did not envision being given the honor to introduce him at such a special event as today. By the time I was 8, I was participating in what is known as the United States Transplant Games with Gift of Life's Team Philadelphia, which is an athletic competition for organ donor recipients. There was Howard again at the Team Philadelphia luncheon beginning our week in Michigan. This time, he was asking the youngest and oldest transplant recipients on our team to identify themselves with an Olympic clasp of the hands. I was the youngest that year as 8 years old, and I joined hands with the oldest, who was 82. I looked up, and in that moment, I saw Howard looking down, this look of pride in his eyes that was so profound that the moment remains with me like a picture. Over the years, Howard has never been far from my life, and so I can tell you these great things about him. He's a true problem solver, the kind of person who is always looking for ways to help someone else and to build a strong community. He's funny too, but you have to make sure you pay careful attention to his jokes. But they always have important messages, and he's a force, inspiring me to become an advocate for organ donation.
We would like to send the praying to the soul of Zahra. May God bless the donor who donates his heart or her heart to her. آمين رب العالمين وصلي يا ربي على محمد وآله الطيبين الطاهرين.
Zahra, before the heart transplant, she was loving, caring, big-hearted. She loves life, very joyful.
My name is Zahra, and I'm a heart transplant recipient. I play a lot of sports. I play basketball, field hockey.
She loves to do a lot of help in the community, especially through the school. She did a lot of dance with disabled.
She was always giving. She had a lot of ambition, a lot of goals.
I started noticing about Zahra's severe cough, runny nose.
I would be so tired, even though I got enough sleep and everything, I would still be tired.
And the doctor told me there's something going on with your daughter's heart. It's really something really bad.
I would never think anything would be wrong with my heart. I was so active and everything.
So they told me, Zahra, she has cardiomyopathy. She needs a heart transplant. I felt the whole world collapse over my head.
Coming from a very, very small Arabic household, usually you have a lot of kids in the family, but since it's only me and my sister, she was my backbone, She was the only thing I had. So she was the baby, not only in my mom's heart, but my heart too.
I cried a lot. I kept calling friends and family members, and I told them, please pray for Zahra. Pray for Zahra. The only thing I had, just prayers.
And I cry and pray, cry and pray, cry and pray.
I called my mom at night. I was like, Mom, make sure you keep your phone next to you.
All of a sudden, 4 o'clock in the morning, I was still praying. And all of a sudden, I received a phone call. My heart was telling me there is something gonna happen tonight. She said, yeah, Hannah, we found a Zahra heart. I couldn't believe it. People were celebrating Valentine's Day. And us, we were celebrating Zahra's heart. The surgery went really well. They said she's really a strong person. She was one of the fastest recovery.
At moments, I forget that I had a heart transplant. It's so normal to me.
It enhanced her. It gave her more purpose in life.
My transplant journey played a big role on what I want to be when I grow up. I want to be a pediatric cardiologist and work where I got my surgery at.
يقولون إنه عندنا كمسلمين إنه عندنا حرام. لما أنت تنقذ حياة واحد يعني شنو الحرام اللي فيها؟
Zahra was the most powerful child I ever met. Before her last breath, she had a video went viral to let the world know she's happy, even though she was in so much pain.
My mission is to educate people my age to become donors because your destiny still lives on.
You're always going to be in my heart. And you are my angel from the day you were born till today.
She's like the perfect little girl. She loved dancing and singing and playing with her brothers. JJ, what you doing?
I'm hugging her.
Our daughter passed away 3 years ago. She was in a horse riding accident and she received a traumatic brain injury.
Riding horsey.
This is what you wanted to do today.
Yep.
She really wanted to ride her horse that day. A car came up the road and spooked the horse and Taisley fell off and hit her head. I called AJ, he was at work and he came as fast as he could.
So I got there and seen Taisley on the ground, and after that my world just stopped. It was like slow motion. Sorry. It was just, if you don't think your own kid's gonna die.
We were ultimately just trying to make the decision. If she doesn't come out of it, what do we do? And trying to make that decision to donate her organs was really hard. Because it's not the way you picture saying goodbye to your child. There just wasn't anything we could do, so we decided to help as many people as we could. We just knew that if Taisley had a say, she would want to help as many people as she could. And so that's why we did it. To help all the other kids and all the parents so they didn't have to go through what we were going through. We've written letters to all of the recipients. Her heart recipient, we're actually really good friends with now. We were able to meet them. He's the cutest little boy in the whole world, and he calls us his heart mom and dad. The first time we met, they brought a stethoscope and we were able to listen to his heart, and they gave us a Build-A-Bear and they got her heartbeat from the hospital. From the moment we decided to donate organs, we just wanted to stay connected. That was like a part of us, a part of Tay. And so we just sat on pins and needles till we got our first letter. And they sent us a whole packet of letters from their entire family. They're just so grateful that we gave them the chance to let their little boy live. I'm just so grateful we got to be Taisley's parents and the example she was to us and the impact she's made on so many other lives, and make it worth something, you know? I don't want her to be forgotten.
Just knowing Michael, he was into saving lives. I mean, isn't that the ultimate gift? A life that continues to give life. And especially with Roxanne, she is probably the most inspirational person that I've met, and what a better person to receive a young heart.
Life. Michael means life to me. And every single morning that I wake up and my feet hit the floor, I thank him.
Anthony was our only son.
He was a good student. He was a musician. He was part of the elite Master Singers Choir. He loved sports. He loved the camaraderie. He loved being part of a team. He had an immense ability to connect with anybody. He was the one that would come up to somebody having a really bad day and make them smile. I knew within seconds of the doctor telling me about Anthony that he was going to die. When Anthony received his license, I was there, and I was at the counter when he was asked about organ donation. I explained, and he said okay. And so he signed up and he registered when he got his license. Little did I know he'd be an organ donor. But when we knew he wasn't going to live, there was comfort in knowing that others would. Our faith played a big role in our ability to deal with the grief of that moment. We know that this life is temporary, and what we make of it is what counts. We are passionate about a partnership with Gift of Life. I just think that the most unselfish thing you can do at the most excruciating moment of your life, when you're losing a loved one, is to give life. He gave his 2 kidneys, he gave his liver, his corneas, and multiple bone and tissue and skin samples. I was told that that will benefit close to 50 to 100 people. I know that generations will come to be because Anthony lived and because he died. And there's a beauty and a power in that that is really amazing. There have been so many people who've witnessed our Gift of Life donation and have made decisions to be donors and to have conversations with their children about it. Our daughter is a really strong young woman. She's made nearly a full recovery physically. She grieves with all of us. She knows the benefit of his organ donation to the families who've received them. Our daughter has taken on this mission by establishing a Gift of Life club to bring awareness to the kids before they get their licenses, and to arm kids to bring literature home for the parents so that we can educate the parents on the process as well. We established the Anthony Pena Foundation as a way of honoring who Anthony was. We didn't get the miracle that we wanted in having Anthony live. I think in many ways he's had more of an effect having passed than perhaps he would have in life. There are people who say they love you a lot more to each other, hug each other a lot more than they used to because of the tragedy we've been through. I know that his impact has reached masses, and that's a gift.
We are meeting my donor family, and it's a really awesome thing. I'm really excited about meeting them. I needed a heart transplant, and so I would not have survived had it not been for the transplant. I can't say how much it means to me.
Thank you. Thank you.
I brought you a picture of my son. That's how happy he was. You know, Henry was our only child.
Okay.
And he was very, very happy and generous, and, you know, he liked to help people a lot. So I know that he's happy with you.
and I'm very happy with him.
Yeah. Well, I'm very happy. Yeah, I'm looking at your stethoscope. Can I use it?
Would you like to? Absolutely. We brought it for you. Yeah.
The big side goes there.
That's my boy.
That's your boy. That's your Herbie.
It's incredible. Never would I have thought that I would be hearing his heart again. You're happy, but you're sad and nervous and excited, and it's just all a bundle of emotions. Kind of hard to describe. We have an extended family now.
I'm very happy and very thankful that Herbie was a donor, but it's also, sad knowing what you folks are going through.
I wasn't thinking in donating the organs, but just listening to him, okay, it just gives me a little bit of closure, gives me a very special feeling to know that he's there.
Everywhere I go, I tell people about the importance of organ donation because I'm a living witness, I'm proof. I came to the point that I knew I couldn't get no better. I said my God was gonna heal me, and my wife prayed for me. I then took the matters out of my own hand, and I let go and let God. A person gave me an organ that never knew me, but that's the love that he had to be a gift to someone else.
Although I lost one of my babies, if God was ready for him, I'm thankful to know that God can take care of him better than I could. I like to say my son saved 3 lives, and the gift of life saved me. You never know if you're going to need an organ or if someone close to you is going to need an organ. Saying yes does bring a smile to your face, knowing that your loved one is a hero and is saving lives.
My son was going to die that day.
She made a decision to save other folks, to save me. She's a hero to me.
The grief of losing a loved one can be overwhelming. In the midst of your pain, you can bring some joy to the situation.
God orchestrated this thing for us to come together. What she did for me was nothing short of a miracle.
Whether you call him God, Allah, it can bring anyone together.
When I got the call, it was the 7th day of Hanukkah, December 23rd, 2014, and I received my miracle, my gift of life, on the 8th night and 8th day of Hanukkah. There's a symbol of Hanukkah called a dreidel. I carry a small dreidel in my pocket every day, an Israeli dreidel. The letters are Nes Gadol Haya Po. A great miracle happened here.
Our faith played a big role in our ability to deal with the grief of that moment. We could gather in the final moments of his life and pray the rosary and essentially turn him over to God. Part of our giving his organs was knowing that Anthony's life purpose may have been fulfilled, that his dying may have been so that others could live. I just think that the most unselfish thing you can do at the most excruciating moment of your life, when you're losing a loved one, is to give life.
My name's Monica Matson, and my husband's Tyler, and we have 7 kids together, and I just want to tell you a little bit about our daughter Mackenzie and why the girls did the lemonade stand, and we're so thankful you're letting us speak here today. Our daughter Mackenzie Matson was born with a heart defect in 2005, and at the age of 17 months she received her first heart transplant. 12 years later, her heart went into heart failure again and got put back on the transplant list, but this time it was for a heart and kidney, waiting for over 300 days in the hospital. Her miracle we were all waiting for never came, and she passed away a year ago today. We love and miss her so much, but we are so grateful for her donor and the family for giving us those 13 extra years with our sweet girl. Mackenzie loved everything from baking goodies but not eating them. She spent time with family. Her and her brother Braxton were inseparable. She loved her friends, she loved going camping, her favorite place was Arches, and she loved selling snow cones every summer outside her house. She knew when she was little she wanted to become a pediatric cardiologist when she got older so she could help kids like her. Mackenzie was a huge advocate for organ donation awareness. She had the opportunity to speak at a symposium. She also spoke at the Celebration of Life in front of 1,000 people. She even participated in the transplant games when they came to Utah in 2018. This is the reason our daughters Miley and Michaela came up with the idea of the lemonade stand that they bought with their own money. They wanted to honor their sister and her love of selling snow cones, but they thought lemonade is easier to distribute for a crowd, so they decided to go that route. They wanted to raise money for organ donation awareness and honor those donors, those that never received one in time, or help those who are waiting. They just want to raise awareness, just like their sister Mackenzie. We sure love and miss Mackenzie and know she is helping her sisters continue to promote organ donation awareness. My girls couldn't have handed over this check that we're about to present without the county council that donated $1,500 and our friends and family and the community that came together to help my girls by donating and buying their lemonade. The impact that my girls have made this past month has been amazing to watch, and I know Mackenzie is so proud of them. My girls are excited to be able to do this next June to continue the effort to raise awareness for Donor Connect. If you are not an organ donor, please consider saying yes on your driver's license and also let your family know your wishes. It could save up to 8 people's lives. My girls would like to come up and present the check to Donor Connect, and then after all this, they want to give you guys lemonade and cake pops that they've made.
Congratulations to the Alliance and happy birthday. What a wonderful way to celebrate 15 years of saving lives. Thanks for everything you do.
Congratulations to the Alliance for 15 years of bringing the transplant community together to advance the field of organ donation and transplantation. Here's to many more years of success.
Sophia, it's time to start.
Welcome back, everyone. I have thoroughly enjoyed the conference speakers today. Such a great conference, and the information has been phenomenal. We also hope you have also enjoyed your time with our poster presentations. We were so privileged to have some incredible research work done with such great insight from those great abstracts. So if you have not had the opportunity, please take time to view all of those virtual presentations. You should do that as soon as you can. My name is Dr. Sophia Smith, and I'm a pediatric emergency room physician with Children's National Hospital here at Washington, D.C. I have been so privileged to be a part of this planning committee for the National Donor Management Summit and watch all this great work come together. Our next presentation is a topic of ever-increasing interest within our field, and we're so pleased to bring you such an incredible panel of diverse perspectives to explore the recent advancements in DCD heart and lung procurement and the ethical considerations associated with these practices. First, we'll hear from Glenda Bronner, Performance Improvement Specialist at UNOS, who will introduce the new DCD Collaborative in the improvement project underway. Next, we will hear from Dr. Pedro Catarino. He's the director of aortic surgery at Cedars-Sinai in New York to give us the perspective of DCD heart recovery and utilization. He will be followed by Dr. Marcelo Cypel, professor of thoracic surgery at the University of Toronto, to discuss DCD lungs. Finally, we'll hear from Dr. David Magnus, a professor of medicine and biomedical ethics at Stanford Medicine, to address the ethical issues. Glenda, we'll begin with you.
All right. Thanks so much, Sophia, and hello, everyone. It's an honor to be presenting today. I'm not sure if I'm live yet. Okay. Thanks so much, everybody. It's an honor to be presenting today. Thank you so much to the Alliance and the Planning Committee for this opportunity to share more about this OPTN DCD Procurement Collaborative. I've been serving as the lead for this effort, but by no means have I been sailing the ship alone. So I want to thank my team, Beth Overacre, Susan Humphreys, Kate Brightfield, and Heather Neal for helping me man the sails and keeping this thing going. Next slide, please. Can't seem to get it to go. I don't have anything to disclose, so I'll just get right to it. Next slide. So just a quick overview for what I'll be sharing today. First, I'll go over a little bit about our approach with collaborative improvement or CI projects, and then I'll dive right into the specifics of the DCD effort, and then elaborate on some of the projects that are going on. And then I'll close out with what we've learned so far and then our next steps. Next slide. So I'm sure that many of you are familiar with the basics of a collaborative improvement project, so I'm not going to go into the weeds here. We follow a model that's adapted from the IHI collaborative framework, and we really try and focus a lot of our efforts around supporting the all teach, all share, all learn mantra. Each of our projects gets its own platform where participants can have the opportunity to engage in a variety of different ways. I'm just going to highlight a few of the key components here today. There's a discussion board where participants can pose questions, share challenges, share successes with each other. Each project has a personalized data dashboard where participants can not only see their own data that's related to all of the project measures, but they can also see other participants' data as well. There's a page for resources that houses both resources that the collaborative team uploads, as well as any resources that participants wish to upload themselves to share with each other. We host collaborative calls and various webinars throughout the project. And then aside from hosting all of the various events, the collaborative team is available throughout the entire project for individual coaching or whatever other assistance might be needed. And then if you want to learn more about our project, we have our own tab on the OPTN website. So feel free to pop on there and look under improvement to find out some more information. Next slide. And then click one more time for me, thank you. So that was generally our approach and the components of the CI projects, but I want to briefly touch on what even makes a good project to begin with. Click one more time for me. We really stress that our projects are not research projects. They're not policy driven or compliance related. When we choose a project, we try and find a focus where there's already an identified gap in practice. So some organizations are doing something really successfully, and others aren't quite realizing that same success, whether it be in volume or outcomes or whatever the subject might be. Furthermore, not only is there that gap in practice, but the community has a desire to close that gap. It's an area where across the board, organizations and programs are saying that they really want to improve. And that sets us up to be able to come in and use our framework to jump in there and help participants make those improvements. And then we always ensure that our projects are aligned with the OPTN strategic goals. Next slide. So it was determined that that DCD procurement was an area that really checked all of those boxes. So we moved forward with an effort to identify some effective practices that we could share with the cohort to try and make progress in that area. And I want to quickly note that while I realize this session is focused on a DCD heart and lung, our project was not limited to those two organs. Our overall goal was simply to increase our participants' DCD donor procurement by 20% from 2020 to 2021. Next slide. And speaking of our participants, here are the 26 OPOs that joined us in this effort. You can see that we really had a nice representation and a nice variety and across the nation. Next slide. So those organizations work to increase DCD procurement by focusing on projects that fell within these three areas that you see on the left, which were determined in our project development to be the three key drivers for improvement. So we structured our improvement guide around these themes and then listed several possible interventions for participants to test. So for example, you can see the first category is to optimize clinical practices and staffing structures. And then an example of an intervention within that bucket is to broaden the criteria for a suitable DCD donor. We were keenly aware that our OPOs were all starting from very different places, so we weren't prescriptive with what we had everyone work on. We wanted to really allow organizations to have the freedom to choose their own projects based on their own needs and their own capabilities. And then in doing this, we learned that many of our OPOs were facing similar challenges and they had projects with a similar focus. Next slide. So here is an example of one of those challenges in the middle, and then also a little peek into how one challenge can be kind of tackled in several different ways. So you see the issue is rapid DCD. Sometimes it's called rapid withdrawal case. And this was a scenario that many OPOs were having trouble and wanted to focus their improvement efforts. And then the surrounding boxes are representative of different projects that were done. And I'm going to elaborate on two of them. So I'll start with the bottom right corner being enhanced donor hospital education. So one way this was done was educating donor hospitals on just the language used, both the language that might be heard the families using to indicate that they're ready to have that donation conversation, as well as language that the staff was using with the families. And then moving to the box in the top left corner, we had one OPO that chose to really hone in on one specific area that they felt would have a big impact on their overall process, and that was just communication. So there's a lot of moving parts and a lot of people involved in these cases, and what they were seeing was that people were sometimes calling, sometimes texting, emailing. They saw really just the gambit being used, and they wanted to know, what's the most effective platform that we can get everybody that needs to be involved in just one consistent stream of communication to help this process run a little smoother. So they got their team together, they tested out different methods, they gathered some feedback, and then they found out what worked best for them. And then where the collaborative was really able to provide a positive impact is that the OPOs are able to share these projects with one another. They're able to ask questions and get feedback from one another, and also just kind of providing a space to gather some more ideas to find out what they might want to take back and work on after hearing what other OPOs were working on. Next slide. So I've touched on this a little bit throughout, but what we saw through this project was that even though we had a lot of variety in the opioids involved, from geography, volume, et cetera, there are still some key challenges that are commonly seen. And what we heard from our participants was that they really appreciated the opportunity to discuss and face those challenges in this collaborative space, and that had a positive impact on their projects overall. And luckily, so far, the data is backing that up, and we're tracking to at least meet and potentially exceed our goal of that 20% increase. So after seeing that the collaborative was having this positive impact, it was determined that we're going to launch a second phase of this project. So we are going to be reaching out very, very soon to all opioid leadership to recruit and see if there are some new organizations that want to come play with us. And we're also going to be allowing any of our current participants to continue on with us, if they would like to do so. And we, of course, hope that they would all like to do so. This has been a wonderful group to work with and made this project really a joy for me to lead. So stay tuned on that. There's going to be more details to come out. And that wraps up my presentation, and I'll be happy to entertain any questions at the end. Thank you so much.
Hello, everyone. I'm just going to launch straight in. I'm not sure I have control. Click next slide, please. So I have no disclosures. Next slide, please. So there are basically three broad options for doing DCD heart procurement. I'll address each along with giving you some of the latest results of outcomes and leave you with the main questions which are still outstanding. Next slide, please. So DCD heart procurement is all in the Maastricht category 3 donors, so-called controlled, where there is planned withdrawal of life support. And I just put up these steps to emphasize the big problem that we have, which is the time delay from circulatory arrest to surgical exposure of the heart. And this is never less than 15 minutes, and typically it's more like 30 minutes. So this is a period of global ischemia where the patient is warm and there's stasis of blood in all the organs. And what does this mean in reality? So next slide, please. So on the left is DVD heart procurement. See how pink everything is? The heart is beating, its function can be assessed, and all the tissues are perfused. Click again, please. Can we go back one? And just click on the right video. Anyway, on the right was an example of what happens with DCD, where the surgeons have exposed the heart, but it's dusky, it's flaccid, dilated, this video showed that we still had to give heparin at this point. Next slide, please. So first, let me just mention co-localization. So this is where the donor and recipient are in the same hospital, often in adjacent ORs. It was, of course, the method of procurement in the early days for Barnard and colleagues in the 60s, until we had brain death criteria and laws. But it was resumed at Denver Children's Hospital for a small series of pediatric heart transplants, here reported in the New England Journal in 2006. And here the donor heart was explanted and immediately sewn into the recipient, who was in an OR next door. And this group were using decreasing standoff periods from 3 minutes to 75 seconds. The results were excellent, but there were ethical concerns, and it's not really a very practical option, so it's largely been abandoned. Next slide, please. So the next option is direct procurement, where basically the heart is explanted as quickly as possible and then reperfused outside the body on a portable perfusion apparatus. And namely, this is the Transmedics OCS. So I've put out the steps here to show you how many different events have to happen, but I have it better explained in a series of videos, which I hope will work. Next slide, please. So first, the first step is to drain the donor blood by cannulating the right atrium, which you can see being done here, and drain off about 1.2 liters of blood, which is important for priming the machine. And it's important that the liver team just hold off their cold perfusion for about 60 to 90 seconds to allow this to happen. And then just, thank you very much. So then that blood is run through a leukocyte filter and into the OCS machine where it's warmed, and that's what's used to perfuse the heart. And meanwhile, back at the heart, yes, please play that one. The first step is now to run cold crystalloid cardioplasia into the heart. And we actually supplement this with nitroglycerin and erythropoietin, which are to attenuate the ischemia reperfusion injury. Next slide, please. So then the heart is explanted, and here you can see that a connector is being put in the aorta. And next video, please. Could you go back one and try and play the middle video? No. The other step is to cannulate the PA, and then the final, yes, which you see here. So the pulmonary artery is also cannulated, and then final video. The heart is basically then connected up to the OCS. And here you can see that by running the blood through the heart's reanimated and is beating. Of course, it's unloaded, so it's not doing work here, and it can be difficult to make a functional assessment of this heart. And we largely rely on the amount of lactate in the circulating blood, the overall lactate, and the difference between the aortic and the PA lactate. Next slide, please. So this is a video of the next option, which is NRP, normothermic regional perfusion. And here, the donor themselves are cannulated and connected to ECMO so that the heart can be reperfused in situ. And here, the abdominal team have done the cannulation in the abdominal aorta and the IVC, and the cardiac team have focused on ligating the blood vessels to the brain, which are coming off the aortic arch. And here you can see they've been ligated, and we've also put cannulae in the distal blood vessel to prove that there's no perfusion of the patient. Next slide, please. And this is the ECMO circuit which we use. It's a commercially available portable ECMO called the Cardio Help, but you can use any homemade or your own unit's ECMO circuit. We've added a reservoir to this system in order to allow us to recirculate the shed blood. And next slide, please. And then a key thing with the NRP is that you run that ECMO for 20 to 40 minutes, during which time, of course, the heart reanimates and then is reconditioned. But then you wean the ECMO off, and then you leave the heart supplying the circulation minus the supraaortic bed. And that allows you to assess the heart just as you would for a DBD with either echo or Swan-Ganz, and allows the abdominal team to proceed as they would for a DBD procurement. Next slide, please. I just put up the steps for NRP so that you'd have them there, but the key thing and the difference from the direct procurement, which is up on the top right, is that because you've done the functional assessment in the donor themselves, you can start the recipient operation earlier. And so that allows you to reduce any cold storage or perfusion time of the heart. Next slide, please. So this is a timeline of what's been happening with DCD over the years. Probably the thing to emphasize is that the US DCD heart study, which started in 2019, had a very successful recruitment and finished just a few weeks ago. And that has been an evaluation of direct procurement and will be very important to guide us forward. And at this point, there have been around 500 DCD heart transplants to date worldwide with that distribution in procurement technique. Next slide, please. There are two big centers that have reported their 5-year outcomes. On the left is Sydney with 32 cases with a 95% 5-year survival, and compared in that chart with their unselected DBD transplants. And on the right is Papworth from Cambridge in the UK, where they have compared 79 DCD hearts with an 88% 5-year survival. And in this case, they've matched 79 DBD hearts and shown that their results are equivalent. Next slide, please. So I can't really say much more beyond that as far as outcomes. They seem to be broadly equivalent. In the early period of the various studies, the PGD rate seemed to be higher than for DBD, 10 to 30%. But this isn't really PGD like we see in DCD. It's much more of a stunning, and most centers had a quite low threshold to start ECMO. And I think that this PGD rate has really come down to the 5 to 10% range. Enthusiast centers can really increase their volume significantly, and overall, I would expect us to be able to increase the national volume by 10%. And we really look forward to the results of the US DCD study at ISHLT in next year. Next slide, please. There are a few things we still don't understand: longer-term outcomes. What's the maximum tolerable warm ischemic time? What adjuncts we could use, and how to assess the heart when it's unloaded on this machine. Next slide, please. But really, DCD heart transplant is an incredibly valuable option to extend heart transplantation. And I would go as far as to say it's the biggest advance in heart transplantation since the introduction of cyclosporin. Next slide, please. So thank you very much, and I'm happy to take your questions at the end.
Dr. Smith, I believe you're on mute.
Yeah, hi. I'm just requesting control here. So I'm going to talk about DCD lung transplantation. These are my disclosures. So I'm going to talk a bit about the utilization and the outcomes of controlled DCD for lung transplantation. And then the initial experience using uncontrolled DCD for lung transplantation in North America. And then also new opportunities for controlled DCDs. I think you're all familiar here, but the main differences between controlled and uncontrolled DCDs are clearly explained in this graph, where basically the option for organ donation in the controlled DCD happens prior to the termination of death, whereas in the uncontrolled, the option for organ donation only happens, of course, after the termination of death, and there are many other differences as well. One of the important advantages of lungs in terms of DCD organ transplantation is that the lung, differently from than all other organs, it's able to maintain cellular viability in the absence of circulation when you keep the alveolar spaces inflated with oxygen. And this provides a big advantage for lungs in the DCD practice. Generally, the controlled DCD timeline includes a period of withdrawal of life-sustaining therapies where teams would wait up to 180 minutes, depends where you are. And then you have the cardiac arrest, 5 minutes standoff period, and then you have the true warm ischemia, which is basically after you have no circulation. And that's usually in a range of 5 to 30 minutes, and then you do the cold flush. It has been a substantial multi-organ donor pool. Just that you have an idea, in the US is about 16%, in Canada 21%, in Ontario is 32% of all our lung transplants are actually DCDs. And of course in the UK and Australia and Europe is quite variable. As you know, some countries are very high use of DCDs and some it's not even allowed. Here in Toronto, just again to show you, it has significantly increased the number of DCDs over time. And just that you have an idea, in 2019, almost 40% of our lung transplants were from DCD lungs. In terms of survival, here, this is data from, again, from our own center, about 180 cases of DCD lung transplants showing completely equivalent survival compared to brain death donors, and also in terms of ICU stay. Now, this is a review from the ISHLT registry, and this included over 1,000 DCD transplants performed in all continents. And you can see here again that the 5-year survival between DCD and brain death donor was completely equivalent. So, you know, in 2021, there is no question that DCD lung transplantation, it's a very viable strategy. And if you're not performing DCD transplantation, you know, especially, I would say, I can speak here for lung, you're really not providing the best standard of care for your waitlist patients. In terms of, again, the DCD is in somewhat in between in terms of timelines between NDD and tissue donation, where, again, there's two types: the planned withdrawal, which is the controlled DCD, and then the unexpected death, which is the uncontrolled DCD. And the uncontrolled DCD has been much slower in terms of adoption. Basically, category 2 must reach is the unsuccessful resuscitation. So someone had a cardiac arrest outside the hospital and is declared dead, in emergency department, for example. So you have a failed resuscitation, and then determination of death, rapid referral and limited assessment, and the opportunity for organ donation and consent. And then organ procurement. And in terms of the timelines you have here, it's a pretty fast timeline. You need to sort all this out. Normally about 180 minutes is what the lungs would tolerate after a complete absence of circulation. This is what some of the preclinical studies performed by our group and others have shown. One of the important things that we adopted, again, for uncontrolled DCDs here is the use of this CPAP machine. So as soon as you have the death declaration, the lungs are inflated and kept inflated until the consent is obtained, and the transplant team can go for the retrieval. Again, I'm talking here now about uncontrolled DCDs. And that gives you time for the recovery team to reach out to the donor hospital. One of the critical features to be able to practice uncontrolled DCD is the use of ex vivo lung perfusion, whereas in the controlled DCD, it's quite clear that EVLP is not mandatory or needed routinely. For uncontrolled DCD, that's the case because you have no idea of the function of these organs. We recently published, this was the first and only experience of uncontrolled DCD for lung transplantation in North America, which we published last year, was just the initial experience. We just look at PGD as the primary endpoint. And again, you can see that the utilization rate is still relatively low in these donors. Again, this was the beginning of the experience where out of 30 potential donors, we end up transplanting 5 of those. And you can see here the timeline is basically you have a period of cold ischemia, of course, the period of warm ischemia, which is the time from death to cold flush, which was variable between 1 hour and 40 minutes and 3 hours and 19 minutes. and then you flush cold the lung, you transfer to the hospital, you do EVLP, you cool down the lung again, and then you do the transplantation. And you can see here that we had organs, lungs that had about 20 to 25 hours even of total preservation time prior to transplantation during this process. And we had really excellent outcomes with this experience, and we didn't have any patient developing PGD3 after transplantation, and the median ICU stay was 5 days, and the median hospital stay was 17 days for this population. And this was the last follow-up. We had 4 out of 5 alive, and 1 patient died of ischemic complications in the gut, which was a patient that was bridged on ECMO. This is an example showing how beautiful these organs can be. So this recipient that received this uncontrolled DCD lung, and this was the lung on EVLP, and he was extubated to room air 12 hours after transplantation. So what we have learned in terms of the uncontrolled DCD is that this is also possible in North America, not only in Spain, which has been, the main country that has done some lungs on uncontrolled DCD. Donor organs can be excellent, and the consent rate was actually quite high, but the utilization is still low, and we need to improve upon organ preservation in these donors. So the organ utilization was only about 50%. So, I think there are things we can do to improve this. I'm sorry, and I'm going to talk briefly about one of them. One preclinical work we've done that showed much better lung preservation inside the person after the donor dies is to have a prone position, because you have a much better distribution of air and oxygen through the alveolar spaces, and these have shown to be highly beneficial in the preclinical model, and we have adopted now this to the clinical protocol as well. The other important aspect is what is the limit of time that we can actually wait in controlled DCDs after withdrawal of life-sustaining therapy. As you know, most in the US is about 1 hour, 90 minutes that teams would wait. We would wait here up to 3 hours. But what we're doing now is that if the donor doesn't arrest within 2 to 3 hours, the team comes back home. But when the donor arrests, we're called back in to do the organ retrieval. So this is a situation, and this is very helpful too for the rapid DCD approaches. And 12 hours after withdrawal of life-sustaining therapy, we recover these lungs, and they function quite well. So this, I think, has a great potential to increase DCD utilization, again, showing this specific case with good lung function. And just to finish, although in the United States, medical assistance in dying is still not approved as a method of organ donation, in Canada is approved, as well as many places in Europe. And some of these donors, actually, they don't want to do the MAID procedure at the hospital. And so what we envisioned here was actually to allow the donor to have the MAID procedure at home, and then apply our strategies that we use for uncontrolled DCD to inflate the lungs and prone the donor and bring to the nearest hospital and perform the organ retrieval, put on ex vivo lung perfusion, and transplant. So we've been able to accomplish this as well. Now we have done 3 transplants from MAID, where the MAID procedure was done at home. And you can see here how excellent this lung looked like. Here is the ex vivo lung perfusion showing the physiology of the lung, also showing excellent physiology in terms of gas exchange and very low lactate and very good compliance as well. And this is the recipient outcome, which was extubated in 24 hours. So to finalize, DCD has substantially increased donor lung availability for lung transplantation, and the outcomes of controlled DCDs are certainly similar, if not better, I would say, that brain death donors. And the experience with uncontrolled DCD will open an amazing opportunity for lung donation, which was not thought to be possible before. So I'll finish here. Thank you very much.
Thank you, Dr. Cypel. We'll turn now to Dr. Magnus.
Thank you very much. Very great pleasure to be here. I have no conflicts of interest to this financial conflicts of interest to disclose. So I'm going to talk about a few issues, ethical issues that arise in donation after declaration of death by circulatory criteria. The first, whether or not those patients who are the typical donors in DCD are actually deceased, which has been something of a controversy. New protocols, including the ones you heard today about opportunities to potentially get hearts from DCD, what some of those do create some ethical challenges, and I'll briefly talk about those. Then I'm going to talk about things that are probably going to be less popular with this group, but I think are important, which are some of the ethical tensions that arise in management of still living patients who are going to be donors, and particularly what happens in futility cases when the family does not consent to the withdrawal. I unfortunately don't have time to really talk about the research ethics issues around innovation and who should consent under those circumstances. So the starting point, the bedrock, is the dead donor rule, the prohibition against removal of organs necessary for the life of the patient. Another way of alternatively thinking about this is there's a prohibition on intentionally ending the life of a patient through organ removal. And I do believe that although there are some attacks on the dead donor rule, it should be defended. It's just a special case of active euthanasia, killing by organ procurement, which is currently unlawful in the United States and all 50 states as a violation of homicide laws. And even with the current legal landscape, as physician-assisted death is spreading, the laws reflect deep ambivalence towards the practice. And I would also add that, as you just heard, even in Canada where euthanasia is legal, they don't do the euthanasia via organ procurement. They first do the euthanasia, then procure the organs. And there's really no evidence of significant major legal or social shift necessary to legalize active euthanasia and hence abandonment of the dead donor rule. Now, the first sort of challenges are dead donor patient, are DCD patients actually dead? The Uniform Determination of Death Act defines a death as an individual has sustained irreversible cessation of circulatory and respiratory functions, and that's what it means to be dead. But what does irreversible mean? Does it mean that their circulatory function will not be reversed because, for example, there's not going to be an attempt made to do the reversal? Or does it mean that it cannot be reversed, even if attempted? And sometimes those two different definitions are characterized as the difference between permanent cessation of circulatory and respiratory functions as opposed to irreversible cessation of circulatory and respiratory functions. But if we decided that the latter is what irreversible means, which is how it's defined in the statute, how long before cannot be reversed threshold is met? And the answer seems to be, maybe with the exception of lungs, too long. However, I think it's really important to note that at the time of the writing of the current UDDA, the commissioners used the terms permanent and irreversible interchangeably. The drafting committee is going to be moving forward with revising the UDDA, and this might be something that can be cleaned up, but those terms were not seen as distinct and were in fact used interchangeably. Moreover, the reason why permanent or the won't be reversed rather than can't be reversed standard is more appropriate is the fact that in non-donation contexts, permanent is the standard, not can't be reversed is the standard. When you have a patient who's full code, the declaration of death doesn't take place until after attempts at resuscitation have failed, whereas for a no-code patient, with a DNR order, the patient is usually declared as soon as you can get a physician in the room after, shortly after cessation of circulatory functioning. So, and I would also add that metaphysically, the idea that the line that divides life from death, the idea that there's a real line that's tied to when resuscitation is impossible, is actually on its surface implausible, because as resuscitation technology changes, so does that line. So really what matters is not how technology changes that line for the definition of what counts as irreversible. What matters is that it's permanent. That's what we really use in general, and that's what really matters. And I think that's how we should currently interpret the regulations, although a UDDA revision could clarify that. So DCD is ethically, in my view, fine in the normal course of things. But as you heard, there are some controversial protocols to expand the pool of DCD donors, and in particular or organs really, and to be able to procure hearts that way. The Denver protocol, which was mentioned earlier, involved waiting only 75 seconds for a couple of those infants. And that was ethically quite controversial because it's not clear that it even reached the permanent stage of not being naturally reversible. And then you also heard discussion of the idea of using an ECMO protocol where in vivo ECMO restarts circulation, but where that circulation does not go to the brain. So are the patients where you use this ECMO protocol really dead? How can we say cessation is irreversible or even permanent if we plan to actually reverse it? And so this remains a fairly controversial protocol. The blood circulation to the brain is not restored. So the question is whether or not that's sufficient to accept a declaration of death. One way of thinking about it as a defense of this approach would be to see this as really just a type of brain death. Because the circulation is not being restarted to the brain, then it's really neurological criteria that would really be the way in which declaration of death is really declared. But on the whole, I think if there are other alternatives, including the others that you heard mentioned in the presentation, to better manage and improve organ retrieval of hearts by essentially resuscitating the heart outside the body, those approaches, if they're successful and produces good outcomes, might be ethically less controversial and therefore might be preferable. I want to end by talking about some tensions in management of these patients. And I should say that I've spent many years as a clinical ethicist dealing with these situations where we have contentious issues around withdrawal of life support for families, and it's very hard for them to accept the terrible prognoses that they're given, and those are often the cases that arise in DCD cases. The core ethical requirement for DCD, other than the dead donor rule, is that the decision to withdraw life support on a living patient should not be made for the purpose of organ procurement, and the implication of that practically is that discussion and consideration of organ procurement is preceded by family decisions to withdraw life-sustaining treatment. So you first have the decision to withdraw life support, and only then do you move forward with the decision about organ procurement. This creates a number of tensions. First is one about timing. Unlike brain death, where we have a much more controlled situation about when the exams are going to take place, the timing of when families will decide to discontinue life support can sometimes be quite variable and often uncontrolled. Not always, and sometimes families are understanding of the terrible prognosis and things proceed in a fashion that we expect. But it's not uncommon for families to be saying, no, we want to keep going, no, we want to keep going, and then suddenly turn on a dime and say, we want to stop, and they want to stop right away. Under those circumstances, OPO staff may be not on site when the decision is made. The families may want to stop very quickly. The families all gathered at the bedside, sometimes without our knowledge that they were going to all come in and do that. And the challenge of having discussion about procurement with family under those circumstances is really, really great. And I would also add that that challenge is perhaps even more acute in cases of a first-person authorization where the family says they want to withdraw, but delays may be required. And after having many days of those conversations and feeling like the family feeling like they're somewhat being pressured to stop, to then have this sudden turnaround by saying, no, we have to continue with life support for a while because of this procurement process, can be very confusing for the family. There are also, I think, although in general, most interests are aligned with donation or procurement and management of patients, there are occasions where there are actually conflicts between other kinds of interests and values that the patients and families have and the interests of the family of the patient in donation. So the patient's family may express, for example, that a patient never wanted to be resuscitated. That's something that they would have wanted, but that might be necessary to keep the donor alive for procurement to proceed, or even necessary in order for a conversation with the family to take place. And that's obviously a huge tension where we're going to have to do something that the patient didn't want in order to be able to potentially do something else that the patient did want. And it's not obvious that for all patients, the desire to be a donor would automatically trump other desires that they would have. Families are sometimes reluctant to accept poor prognoses and insist on all life support for a long time where the teams feel it's really not necessarily appropriate or even in accord with the patient's wishes and values. And one of the situations that we sometimes see is that after a great deal of effort and a lot of time talking to families, we may get them to reluctantly accept the prognosis and that the patient is not going to recover meaningfully, and therefore, in accord with the patient's wishes, they want to move forward with withdrawal of life support. But if they reject donation in a first-person authorization situation, they may respond to recognizing that they won't have any choice over the matter by rejecting the shift to comfort care, even when that's in accord with the patient's wishes. Third tension is around communication. Often with families who are reluctant to accept the prognosis and attempt delay moving forward, there's a sense of urgency from the teams and putting time limits and trying to not allow this to be open-ended, because that's found to be generally a good practice for making the family move forward. But again, there can be a tension between the teams trying to put those time limits on, and then challenging when the OPO wants everything to then slow down once we succeed in getting the family to agree to withdrawal. And then recently we had a case that I had not thought about before as another communication challenge for us in talking to the families, which is that we've been having all these conversations explaining for weeks that the patient's kidneys are shot, that they'll never work again, that other organs are shot and are never going to work for this patient in multi-organ system failure. And it can sometimes be very hard for the families to understand why we can then procure those organs and have them work for someone else when we're telling them that they won't work for their loved one. And then lastly, and this is a very challenging situation, is what do we do when the family just never is willing to accept a truly horrific prognosis that this patient is never going to meaningfully recover? Again, remember, the ethical starting point is that procurement takes place after the family makes the decision to withdraw life-sustaining treatment. But what do we do when the family doesn't make that determination, and instead the teams and the hospital make that determination? In some states, including Texas and California, we actually have the legal option to declare that continued medically life-sustaining treatment is medically ineffective, and that those are going to be discontinued as an unshared decision, not a shared decision, not a decision that the family consents to. So in situations where the family never agrees to withdraw and the hospital and teams have invoked futility or medically ineffective non-beneficial care, first issue is, will the OPO be willing to still speak with the family to potentially authorize procurement when the family is objecting to the withdrawal and they have failed in efforts to arrange a transfer to another hospital, which is their right to have a time-limited opportunity to try and do that? Those are very fraught conversations, and sometimes people from the OPO may be unwilling to even have those conversations. And in the cases of a first-person authorization, we may have a situation where a family is objecting to withdrawal of life support and objecting to procurement, yet both would be happening for over their objection. And I will just say that the optics of that situation could be problematic. It may look like we are killing their patient, their loved one, to procure their organs, which is, of course, something we very, very much want to avoid. How do we resolve all of these tensions? Well, I think the first thing in the first presentation you heard in this panel actually, I think, speaks to some of this. Good communication and coordination as much as possible between the OPO and the teams involved in caring for the still living patient is, I think, critically important for all of this to work well. And it's one of the reasons why our ethics service can also be very helpful in moving things forward. Second, I do think there need to be clear boundaries about what is and is not appropriate, and to remember that unlike a brain dead patient for whom the patient has no interest because there's no patient anymore. The interest of still living patients have to always come first, because in a DCD, they are still living. And that therefore some level of tension is unavoidable. In spite of sometimes claims to the contrary, there are occasions, hopefully rare, where the interest of donation and other interests that the patient and their families have will conflict, and those need to be very, very carefully managed. Thank you very much.
All right, excellent. Thank you, Dr. Magnus. We'll invite Dr. Smith back for Q&A, and Dr. Smith, you may be on mute.
I'm unmuted. Can you hear me?
Yes, we can hear you. Okay, yes. Thank you, Dr. Magnus, Dr. Cypel, Dr. Catarino, and Glenda for an excellent presentation and your incredible insights. We'll go ahead right now, open up for questions from the audience. We will have you until 2:45 to have the discussion. If you have questions for our presenters, please submit them using the Q&A feature on day 2, part 2 session window. But to get started, and again, thank you all for such a great presentation. When we look at lung and heart transplantation, we know it provides a realistic hope of improved survival and enhanced quality of life. And we know utilization of the DCD, donation after circulatory death, has the potential to decrease donor shortage in lung transplantation. But does age matter? Age has been a controversial discussion in general when it comes to any solid organ donation, especially when it comes to hearts and lungs, with the donor pool being so low for each one of them. How does the discussion and decision made when it comes to determining transplanting maybe a younger CF patient as well versus an older pulmonary fibrosis patient? And I guess the second question that would be, does baseline transplant performance play a role in determining the likelihood of a candidate? Should we be transplanting kids versus adults? How does that play a role for cardiac or lung transplant? And anyone can jump in to answer that question.
But yeah, if I can start with the donor age story, I think, it's quite variable what centers tend to accept in terms of donor age. We accept donors up to the age of 80 years old. For DCDs, we put a criteria for 70 years old as the maximum age. And of course, there are many other features that need to put in consideration, smoking history or, any other history of lung problems. But we can have a very good donor lung, 70, 75 years of age, non-smoker, with perfect function. We do tend to use those organs in the pulmonary fibrosis, older patients as well. We have a large number of patients on the wait list in a range of 65 to 75 years of age. And then we tend to match in that setting. But yeah, I think age itself, we don't use that strongly as a contraindication. It's more the combination of other features.
Does anybody else want to have any other questions?
I think there was a question about prioritization of the recipient, children versus adults. And I have to say in hearts, it doesn't usually, there isn't much overlap because size is such an important factor. So obviously the heart has to fit in the space for a child's transplant. And so mostly children's transplant come from other children. And in general, pediatric donors are reserved for pediatric recipients. And in some cases, small adult donors may be prioritized towards pediatrics, but it's not as big an issue as you might imagine.
Excellent. We have a question from the audience. We have transplant centers require patients to be able to care for their organ after transplant. They need to have social support to care for the graft so it isn't lost 24/7. I feel we turn down a lot of minorities because this doesn't actually exist for them. How do we get past that?
Well, I'll say something about it because I've studied listing decisions and published a lot about the different kinds of listing decisions that transplant centers make for patients. There's no question that social support and many other variables are taken into account. Some of our data demonstrate that there's not a good fit between sometimes the outcomes data and the factors that govern the decisions, and so they may reflect bias. So just to take a few examples, patients who are developmentally delayed are often not listed for transplant, even though their outcomes are just as good. We found that patients who are undocumented immigrants are often not listed for transplant, and it's usually a contraindication, often an absolute contraindication, in spite of having better than average outcomes. And of course, the data demonstrates pretty clearly differences in race and ethnicity in regard to outcomes, although some of those are correlated with actual things that are associated with genuine differences in outcomes. So I think the issue of whether or not having adequate social support should be a factor is controversial. There's some ethical literature about that's been published, but it's clear that it matters some. The question is really how much. And I do think that the important thing there is to really have an evidence-based approach that really is tied to outcomes. My colleague Jose Maldonado and colleagues have developed something called the Stanford Integrated Psychosocial Assessment Tool, and to really use CyPAT, which is continuing to be refined to be more and more predictive, so that when we decide to rule somebody out on the basis of essentially psychosocial factors, we make sure that those are not biased or discriminatory and are based on good evidence.
Thank you, Dr. Magnus. We do have another question from the audience. How do you optimize patient selection? Are there patients more likely to benefit and those that are more likely to be harmed?
So for hearts, there is no restriction on recipients. We have so long as the patient consents to having a DCD heart, there aren't clinical factors which come into the decision.
Yeah, for lung is the same. We don't consent patients for DCD lung transplantation for many years because it's standard practice now. 40% of our transplants are DCDs, so the patients don't even know if they are receiving an NDD or a DCD lung or an euthanasia donor lung. Yeah.
Excellent. We have more questions. Nicole Santra, if in uncontrolled DCDs, when you inflate the lungs after death, have you seen or are worried about autoresuscitation related to oxygenation and inflation of the lungs?
Yeah, that's an excellent question. The important thing here is that we don't do, I didn't have the time to show all the details of our protocol, but we don't do any intervention to the donor for 30 minutes after death declaration. Okay, and so 30 minutes after death declaration, we inflate the lungs and prone the donor, but there's no active ventilation too, it's just lung inflation as well. But that was something we were worried about, and that's why we put this 30-minute timeline.
I think from an ethical point of view, that should be sufficient to really not raise any questions about whether these patients are really dead.
Thank you. We have another question from Debbie Collis. When the patients are at home and they want to be a DCD donor, is the process coordinated by hospice, transplant center, OPO, or other?
I guess you're talking about is this about the euthanasia donors?
She did not specify. Let's see if she gives me an answer.
For controlled DCD, that's really not an option at home. They would have to be in the hospital in general for a controlled DCD.
Okay. How do you handle opposition to FPA on DCD?
Most OPOs will proceed. They inform the families, but families don't have the right to object or override the first person authorization. However, that being said, again, goes back to this issue of communication between the OPO and the hospital and the teams, so that we have good communication with the families. If the families' opposition is, what's the source of it? Is it that they don't accept the prognosis, or is it because they've accepted that they're dead, but they really just aren't in favor of procurement? In which case, those are primarily conversations between the OPO and the families to try and get them to be more understanding. And of course, the biggest risk that we're all worried about is ultimately the families can stop in a DCD. They can stop even in a first person authorization donation from proceeding by just not allowing you to move forward with the withdrawal of life support. So I think we're all very careful about those situations, but that's really the kind of tension that I'm talking about, where we might say, look, back off, because the family's all that's going to happen here is the family's going to insist that we don't withdraw life support in a situation where that's not really a good idea, and the OPO might want to be more aggressive. So you have to have communication back and forth about the right way to handle that. We have definitely had situations like that where the OPO decided not to proceed because they thought it was problematic. But those are, I would say, in a first person authorization, that's pretty rare. And if a patient is a candidate, usually the authorization is the dominant consideration. And usually with enough communication, families can be brought to understand that they're trying to act in accord with the patient's wishes.
Thank you, Dr. Magnus.
I don't know if Glenda might want to respond to that as well.
Maybe not.
I don't know that I can really speak to the exact practices. I just kind of help coordinate the improvement. But I do know that first person authorization has definitely come up a lot with our OPOs, since it kind of varies from state to state how that works. So it's definitely been a hot topic of discussion within our participants.
Thank you, Linda. Another question from the audience. Could you please elaborate more on the patient proning during the dying process? How did you get the hospitals and families on board? What does this process look like?
Yeah, so we don't do any proning during the dying process. In these donors, the prone positioning is only for uncontrolled DCDs that have already had death declaration done, and we still get permission from the family at the time of consent to do that, saying that can help preserving the lung better until the teams arrive at the hospital.
Excellent. They said, another question from the audience is fascinating presentation. What are your upper limits for DCD eligibility?
I'm not clear about this question. Upper limits on what aspect?
In my mind, would it be age?
Yeah, for lungs, we use 70 as the upper limit for age. And if the mentioning here is the interval of time from withdrawal to arrest, and if he or she is talking about that type of limit, again, we use 3 hours as the limit of time generally. Although, again, considering some donor hospitals, the team would go back anytime in the next 24 hours when the donor arrests to do the lung recovery.
And for heart, the upper limit of eligibility in terms of age in experienced centers is 60 years, but many centers that just start off their DCD experience have a lower age limit. And as far as the time, the key thing is that the warm ischemic time, rather than any particular time from withdrawal. And so from when the systolic blood pressure drops below 50, really the heart needs to be either cold perfused or warm perfused within 30 minutes.
We have another question here from the audience. Is asked, general opinion on NRP and ethical issues being brought to light. How do we work through these to optimize donation and transplantation?
Shall I? Well, I'll give you my sort of clinical view on this. I think it's first, the most important thing is that the clinicians are very transparent about what they are doing, about how the death is declared and what procedures the patient undergoes, as part of the NRP. And then with that transparency, there has to be education of the family, and I think consent, buy-in of the family, that this is what is going to happen to their relative, and education of the wider procurement team, and not just the organ procurement professionals, but the local hospital team, has to be comfortable with what's going to happen. I think those are the keys to making NRP acceptable. And I would say that in Europe, NRP is probably much more commonly performed than in the United States, and is very commonly performed by abdominal procurement teams without any intention to take the heart or lungs. That's one of the best ways of ensuring viability of certainly the liver in DCD donors. So I suspect that there'll be increasing pressure to do NRP, and it's going to come not so much from heart procurement, but it's going to come from abdominal procurement.
Yeah, I agree. I think there's going to be more and more pressure to do this. One of the challenging things that we've seen is, given the shortage of organs, there's a lot of pressure. And when lines get drawn, there's a tendency to push right up against those lines and sometimes move those lines in different kinds of ways. There's only been a couple of exceptions that have seen as bright lines that have not been movable. And one of them is the dead donor rule. And so what we're really talking about with these things, I agree with everything that Dr. Catarino just said about transparency and consent, and I agree with all of those things. However, I will note that we really are pushing up against that really hard and fast line of the dead donor rule. And then even if you have consent, we don't want it to be the case that the patients are dying from procurement. And so that really means it's important that the patient be deceased prior to and that it be plausible that they be deceased prior to the procurement. I think that was one of the big problems with the Denver protocol and only waiting 75 seconds, is that they didn't wait long enough. I think for this, for the NRP, it's going to be, I think it's possible for that to be ethically done, but I think but it's going to remain controversial. And so if there are other alternatives, it would be better. And if there aren't, I think we need to think about some aspects of timing, like making sure that the patients have lost neurological function so that we can declare them dead by neurological criteria so that we can avoid problems there. I think it can be managed ethically, but I do think it's important to remember that reasonable people can actually disagree about that, about where exactly we draw that line between when a patient is still living and dead.
Thank you, everyone. Our thanks again for everyone and their fantastic questions, and to this outstanding panel for their exceptional insights on this critical topic. At this time, I'd like to hand it over to my planning committee colleague, Dr. Tommy Thomas. Thank you all.
All right. Thanks, Dr. Smith, and hello, everyone. My name is Dr. Tommy Thomas, and I'm in the Division of Critical Care at Emory University. Before we begin our final segment of the summit, we'd like to extend our thanks to our event sponsors, CareDx. With 2 decades of commitment to transplant care, CareDx is a leading precision medicine solutions company focused on the development and commercialization of high-value healthcare solutions, including testing services, transplant lab products, digital transplant solutions, and pharma services. For more information, visit caredx.com. Now to begin our final presentation. We all know that COVID has drastically changed our world, especially for those of us working in the medical field and in areas of donation and transplantation. We've invited our friends from Johns Hopkins School of Medicine to discuss current research and trends related to vaccines and their impact on donors and patients. Later, we'll explore the clinical considerations of the future variants and its implications for our field. In the chat, please take a moment to share with us what the greatest challenges, clinical and otherwise, your teams currently face as it relates to COVID, and what practices you've implemented to better address these challenges. For this presentation, we're pleased to be joined by Dr. Macey Levan, Director of Policy and External Affairs for the Johns Hopkins Epidemiology Research Group in Organ Transplantation, as well as Dr. Allan Massie, Assistant Professor of Surgery for Johns Hopkins School of Medicine. Dr. Levan, good afternoon. We'll begin with you.
Hi, everyone. Thank you so much for having us. I'm Macey Levan. I am one of our faculty members in the Department of Surgery at Johns Hopkins. I'm also one of the directors, as Dr. Thomas mentioned, for the Epidemiology Research Group in Organ Transplantation. Our research group is the largest transplant research group in the world. We are nearing 100 people, and our primary mission over the past year has been understanding the impact of COVID on not only deceased organ donation, but in transplant patients. And this presentation, I'm introducing Dr. Allan Massie, who is a world-renowned transplant epidemiologist who has published extensively in the literature on every topic related to donation, but specifically has led a lot of our efforts on the impact of COVID. So without further ado, I'd ask Allan if you could advance the slide.
One second, there we go.
Yeah, I would just like to acknowledge that we received funding from the NIAID to run the COVID protection after transplantation study. Dr. Segev is the principal investigator there. I'm also a member of one of the leadership councils for the Alliance. I don't have any other additional disclosures for myself or Allan. And so I think with that, I will turn it over to Dr. Massie to talk about donation in relation to COVID.
Thank you, Macey. And I'd like to thank the committee for the opportunity for us to talk about COVID-19 and donation and transplantation. Sorry, I'm having a hard time advancing the slides. So let's begin by talking about the impact of COVID-19 on deceased donation. Everyone will remember the first wave of COVID-19, which hit the United States in early March of 2020. This figure here shows the number of recorded cases per day. In fact, the true number of cases in the United States was surely much higher than illustrated here in the month of March 2020, but this is when our testing capabilities were first spinning up. So we're going to talk about the impact of this first wave of COVID on deceased donation in the United States. So when there was a state of emergency declared on Friday, March 13th, 2020, which perhaps may be why Friday the 13th is unlucky. As you can see from this figure here, there is immediate and substantial decrease in deceased donors recovered across the United States. So pre-pandemic, then nationwide, there were around 250 donors recovered per week. That immediately dropped to around 150, and then over the next several months, slowly trended up again, reaching pre-pandemic levels around June 1st. So the prior figure showed national trends. When we zoom in on the states that had the highest recorded COVID incidents during this time, which were New York, New Jersey, some of the New England states, as well as Louisiana, then you can see the data are noisier because it's a smaller number, but there's a steeper decline in these states, the highest COVID incidents, about a drop of more than 50%. Now, beyond that, those donors that were recovered during the first wave looks different in their characteristics than donors that were recovered pre-pandemic. So pre-pandemic, the median age of recovered donors is 44. That drops to 40, and the difference was statistically significant. The proportion of donors that were DCD dropped from 25% to 22%. And the proportion of donors that were diabetic dropped from 14% to 12%. And all of these were statistically significant. So it's not huge changes, but it does suggest that there was some slower uptake of potentially marginal kidney donors during the first wave of the pandemic compared to pre-pandemic. However, we didn't see a change in the proportion of donors that were CDC infectious risk donors. Overall, I would say donor selection became more conservative during this first wave. So now let's talk about what happened during the second wave of the pandemic. So this is the title here is incorrect. This is roughly June through August of 2020. Whereas you can see we had substantially higher reported incidence than the first wave, although probably that's partly better ascertainment. Additionally, the geographic distribution was different. So in contrast with the first wave, you can really see that throughout the second wave of the pandemic, that the number of donors recovered per week was really constant at pre-pandemic levels. So this shows that the OPOs in the National Organ Recovery System has recovered from the initial shock of COVID, and there was no evidence of a decline in overall recovery of donors. Even when you zoom in on the high COVID states, which during the second wave were a lot in the Southeast, Alabama, Florida, Louisiana, Mississippi, and South Carolina, as well as some further out west, Arizona, Nevada, we don't see any evidence of a decline. So even in the highest COVID-19 states, there was no evidence of a change in donor recovery. And then when we look at the third wave, which I'm dating from September 1st of last year up until the end of February or March 1st of this year. So looking at this graph here, you can see substantially higher incidence, which I'm sure all of you remember quite well. We can't truly compare this to the unobserved incidence during the first wave, but this was a time, particularly around November, December, of very broad and widespread incidence of COVID-19. Nevertheless, we continue to still see no decline in the number of donors recovered per week. And even when we focused on the highest COVID states during this time, which here are the Dakotas, Kansas, Arizona, again, Wyoming, a lot of mountain states, as well as Rhode Island and Tennessee, then there's no evidence of a decline in the number of deceased donors with organs recovered per week. So what this shows is, in contrast to the first wave, there's really been successful adaptation of our national system to the challenge of COVID-19. So now let's talk a little bit about the impact on transplantation. So these next slides are going to draw from previously published work from our research group by my colleague Brian Boyarsky. There was a substantial decline in deceased donor kidney transplantations during the first wave, and this was particularly concentrated in high COVID states, which had a 41% decline in deceased donations compared to pre-COVID. The decline in DCD kidney transplants was even steeper, a drop of more than half. And there was a near total halt in living donor kidney transplants. This is showing the overall national trends. Beyond these numbers, what happened is that many programs halted living donation entirely, while there were a small number of centers that continued. So these trends were fortunately transient, Deceased donor kidney transplantation was back to pre-pandemic levels, generally by May 2020, and living kidney donor transplants were back to pre-pandemic levels by June 2020. So despite the abrupt decline, the return was also pretty, was also fairly rapid. Okay, now let's talk about liver transplantation during this first wave. So here, fortunately, the effects were not as dramatic. This is drawing work from my colleague Ali Strauss at Johns Hopkins. You can see that there was an immediate, very sudden increase in the proportion of liver waitlist registrants whose listing status changed to inactive. And then there was after this, there was a gradual decline of that back to pre-pandemic levels. However, the effect on the number of deceased donor liver transplants was milder than we saw in kidney and was really very transient. You can see a dip here in March, bottoming out around April 1st and back to pre-pandemic levels by the end of April. So now let's talk about the impact on mortality among transplant recipients. So we're not thinking here about new transplant recipients, just the population of prevalent transplant recipients living in the United States. So there are two graphs here. The first one on the left is showing the ratio of observed deaths compared to expected deaths among transplant recipients between January 2020, so a little bit of pre-pandemic, extending up through the end of February 2021. There's a little bit of a lag here because there's some lag in reliable mortality ascertainment for the national registries. But what you can see is an immediate and very substantial increase in the ratio of observed to expected deaths in every organ starting in March 2021. It was highest in kidney recipients. And then you can, it remained elevated then through the rest of 2020 with, again, sharp increases around November of 2020, staying elevated and then starting to decline in February of this year. Now, the figure on the left is showing the ratio of how much more there is than expected. The one on the right is calculating the number of excess deaths per month. That's beyond the number of deaths that we see in transplant recipients beyond what we would have expected. And almost all of them are in kidney populations by numbers because the prevalent kidney transplant population is so much larger. Here you can see there's a very substantial spike in April 2020, and then it settled down after that, but nonetheless remained elevated. Here, anything above zero represents excess deaths. That's more deaths than we would have expected. And then you can see another giant jump around December 2020 to January 2021. And this is across all organs. In the National Registry, we have cause of death for most of the transplant recipients. Of all of the deaths between March 2020 and March 2020, February 2021, there were about 1,200 deaths that were attributed to COVID. Nonetheless, if we calculate the total number of excess deaths, that's how many more deaths do we see than we would have expected in a one-year period. That's nearly 5,000 excess deaths, 4,740. This is 34% above the expected number. So during this time, about 25% of all deaths in transplant recipients were above and beyond what we would have expected based on the normal population levels. And this mirrors things that we've seen in the general United States population, that above and beyond the number of recorded COVID deaths, we see a lot more excess deaths. And this could be because there are patients who died of COVID and didn't have it reported. It could be undetected infections. It could also be secondary indirect deaths caused by COVID. For example, patients that avoid treatment-seeking behaviors, that don't have scheduled visits, or that have decreased quality of life because they're unable to go out. Here we're looking at excess deaths for various subgroups. So what we can see here for subgroups of transplant recipients, we have the number of observed deaths over this period, the number of deaths that we would have expected based on prior years, and then excess is just the observed minus expected, and then the ratio of observed to expected. So a ratio above 1 is indicating more mortality than expected. Interestingly, the ratio of observed to expected deaths was highest among kidney transplant recipients and lowest among lung recipients, despite the fact that COVID-19 is a disease that affects the lungs. You can see that we don't really see excess mortality among transplant recipients under the age of about 30 to 40, but that the ratio of observed to expected deaths is highest for patients aged 50 and above, particularly patients above the age of 60. Here we're looking stratified by race and ethnicity. The number of excess deaths was highest for Hispanic transplant recipients, whose number of recorded deaths was over 80% above the baseline rate. And it was least for white recipients, for whom it was about 20% above the baseline rate. Some of this may be related to geography as well as to the disparities, of course, that permeate so many aspects of society in the United States. So now we're looking at the geographic distribution of excess deaths. So for each state, we separately calculate a number of expected deaths and then the number that we observed. And here we see 3 maps corresponding to the 3 waves of COVID-19. And what we can see here is that the geographic and temporal patterns of excess deaths match the incidence of COVID-19. So blue is a lot of deaths in wave 1. The most deaths are in New York and New Jersey. In wave 2, they're more broadly distributed with a lot in the Southeast, and in wave 3 in the Southeast as well as the Mountain West. Okay, now let's talk about COVID-19 vaccination in transplant recipients, a topic that's gotten a lot of attention. So our research group demonstrated earlier this year that among patients who get a dose of an mRNA vaccine, only 17% had a detectable antibody spike. This is much lower if patients are on MMF, and interestingly, higher for Moderna recipients than for Pfizer. This is showing the response to the second dose. So what these lines represent is the difference in antibody trajectory from the first dose to the second dose. And anyone who stayed low across both doses is going to be this large orange bulb at the bottom here. But what you can see is that any patient who had any detectable response to the first dose, almost all of them had a very high response to the second dose. So after 2 doses, there was a response in about 50% of recipients. It remains lower for patients on MMF. And as I said, patients who had a weak but positive response to dose 1 tend to have a strong response to dose 2. So we also have published on response to a third dose. Very on, we had some patients in our cohort who were able to get a third dose one way or another. This is a fairly small case series, but among 30 patients who had had a poor response after 2 doses, half of them had a strong positive response. Sorry, not half. Half of them had had a low response previously, and half sorry, I'm getting confused. Sorry. So of 30 patients, half of them got mRNA, half of them got Janssen. All of the patients who had a low positive response previously had a high positive response to the third dose. Of those who were completely negative previously, a quarter of them had a high positive response and 2 additional ones had a low positive response. So very small n's, but raising the hope that a booster dose could help patients who have not had a good response. And we've even published on a 4th dose. So we had 18 patients who got a 4th dose, of whom several of them had a positive response to the 4th dose. And most patients who had previously had a good response continued to have a better response after this booster dose. So as a result of this work and work from other research groups, the NIH is launching a study of booster doses for kidney transplants. We have a pilot study underway right now, and we have 2 trials planned. One of them to test the intervention of immunomodulation. So we're going to enroll recipients who have been vaccinated and had only a minimal response to prior vaccination, and give everyone an additional booster. Half of them are going to have reduced immunosuppression temporarily, covering the time when they're on their vaccine. We will, of course, monitor for safety, look at incidence of de novo DSA, rejection, as well as graft loss mortality. And then also we're hoping to see an increase in efficacy. So that would be post-dose antibody titers. Additionally, we're planning a trial to compare whether a booster dose is more effective if it's for patients who received mRNA, to see if they do better with a booster of additional mRNA versus the Johnson & Johnson vaccine. So a homologous vaccine versus a heterologous vaccine. Here we will certainly monitor safety. Safety isn't as much of a concern, but the main efficacy outcome is going to be post-dose antibody titer. So how is COVID, we've seen the slide. So in conclusion, the first wave of COVID led to a very sharp but ultimately transient drop in deceased donor recovery and kidney transplantation, relatively little disruption to liver. Subsequent waves had no negative effect on donor recovery and transplantation. In this first year of COVID, before vaccine availability, there were over 4,700 excess deaths nationwide among transplant recipients. Transplant recipients have a varying response to COVID-19 vaccination, but generally worse than the general population. However, we've seen that booster doses can boost immunity in transplant recipients. So thinking about this interpretively, the first wave of COVID was an unprecedented crisis really for transplantation in the United States, but the transplant system did adapt successfully. Hopefully lessons from this crisis can be applied to future disruptions in healthcare. I think that's true beyond just organ transplantation. We know that solid organ transplant recipients remain at very high risk of COVID complications and death, even after vaccination. And this is particularly important as we are seeing this new wave of Delta. And we urgently need innovative vaccine strategies to protect our patients. So thank you very much to my colleague, Macey Levan, and all of my colleagues at the Epidemiology Research Group in Organ Transplantation at Johns Hopkins. And Macey and I would be very happy to take your questions. Thank you.
Thank you both for putting together such an insightful presentation. We'll go ahead and open it up to questions from everyone now. We'll have about 5 minutes or so for discussion thereafter. If you have any questions, please submit them in the question and answer feature in the part 2 session window. Some of the questions that we have already. So was it surprising that things remained relatively stable in terms of donor recovery despite the significant disruption from the pandemic?
So from my part, I would say, first of all, I'm an epidemiologist and somewhat removed from clinical care. I would say I personally was pleasantly surprised by how robust our transplantation regime stayed following the first wave, particularly when we had these extraordinarily high incidence rates in the winter of last year. I think that some of the disruption that we saw initially may have been related to healthcare capacities. I know that a lot of hospitals were, closing operating rooms and postponing non-urgent surgeries. There was a question of whether kidney transplantation in particular should count. So I think it's unsurprising that we saw some disruption, but something to be proud of that we saw very little disruption subsequently.
Indeed. So what systems do you think mitigated the potential disruption from the pandemic?
So again, I'm not as closely connected to systems. I would invite Macey to weigh in also, but I think that through society in general, we have, we had to learn how to adapt our procedures in all of the work that we do, and we're able to make those adaptations. Also, we saw hospitals and healthcare systems increase capacity. We had in high COVID areas, there were temporary field hospitals. And so I think it was just a matter of adapting new workflows that made transplantation possible.
Yeah, I absolutely, Allan, that's exactly what I would say. I do think that the transplant community stepped up in a very big way during COVID. And I do think that OPO practices very likely remain the same in some ways, but also maybe were more better in other ways. Again, I don't work in an OPO and I'm not a clinical professional, but looking at it from the health systems perspective, it certainly does look like we stepped up as a community. Again, as soon as transplants were declared a medically necessary surgical procedure, and at least at Johns Hopkins, when our ORs opened back up to that, that made a huge difference. So as Allan did say, that time frame specifically when it was not is something we could do versus when it was, I think that's maybe when we saw the little bit of the dip. Other than that, I think right on with everything else.
Okay. In terms of the effect of COVID on the recipient survival, was that a direct consequence of COVID infection versus other factors like decreased surveillance or the effect of COVID on logistics or medical access? Is that something that you all could kind of discern?
Thanks for that question. So based on the registry data, it's impossible for anyone who doesn't have a direct cause of death. It's impossible for us to say whether COVID contributed in any way. And based on the methods that we're using, while we do see this large pattern of excess deaths, we can't identify which individuals would have survived otherwise. So I don't think that that's a question that we can answer with national registry studies. But at the same time, I think that it highlights the importance of taking a holistic look at patterns in mortality, because if we had only counted the direct deaths, then we would have undercounted by almost fourfold.
Right. Was that stratified according to any kind of socioeconomic or racial group, or was that just kind of across the board?
So we did stratify by age, geographic region, race, and a few other groups. The national transplant registries aren't really great at capturing socioeconomic exposures per se, but we did see the highest increase in Hispanic patients and second highest in Black patients, with the lowest in white patients.
To change gear to the kind of second part of your talk, did you note any difference in kind of antibody titer response and transplant recipient outcomes? Meaning, I think that you associated kind of a higher response to a higher antibody titer, and was that has that yet been associated with any kind of mortality data or survival data?
That's an excellent question, and it's something that we haven't really looked at yet. So, our focus so far has been on looking at short-term immediate outcomes, but we do have a cohort of over 1,000 individuals that we're going to continue to follow. We have had some reports of post-vaccination COVID-19 in our cohort, which we are going to be following very closely and publishing our findings on. In terms of longer-term ramifications, I think it's a wonderful question that we're going to have to look at the long term, but I think it's very important because it's very likely that individuals who are having a lower antibody response probably also have, on the one hand, they may have a poorer response to infections in general. This may be a patient phenotype, that is worse off beyond the context of COVID-19. On the other hand, it could be that because they have more immunosuppression, you could imagine that they might be less vulnerable to rejection and graft loss. So it will be very interesting to see as time unfolds how patients, what the relationship is between the antibody response and subsequent graft survival.
Mm-hmm. Have you noticed any resistance to kind of obtaining the vaccine, or is the vaccination prerequisite in the kind of organ recipient program there?
So in our cohort, then patients have been very enthusiastic and very self-motivated to vaccinate. In fact, when the FDA started recommending dose 3s, it was astonishing to us how many people got their dose 3 that weekend. So our cohort may be self-selected in some ways. A lot of them are healthcare professionals because of the way that we recruited. And I'm sure that there's some vaccine resistance in the transplant community. I haven't seen any reports on vaccine hesitancy. We did do a survey before the vaccine was available that showed low hesitancy. I've seen research that shows in the general population a strong inverse correlation between vaccine hesitancy and age. And so among, for various reasons, there's a strong association between political attitudes and vaccine attitudes in the United States. But you tend to see among the elderly, even people who otherwise you might expect to be vaccine hesitant are getting vaccinated at higher rates. So that may suggest that when people feel themselves to be personally at high risk, they're more able to overcome whatever concerns they have. And I would imagine that could apply to lower age transplant recipients also, but that's speculation.
Indeed. Well, with that, I think we're going to have to wrap up our question and answer session. Thanks again, Dr. Levan and Dr. Massey, for sharing your insights on this subject. And at this time, I'll hand it back over to the Alliance team.
Thank you very much.
All right. Thank you, Dr. Thomas, and to all of our outstanding presenters over the last 2 days. We also want to extend our sincere thanks to all of you for attending the National Donor Management Summit. Now, as promised, we have some gifts for the folks who have been the most engaged over the past 2 days, from posing questions and interacting with their colleagues and contributing valuable insights. So we'd like to thank Amanda Leffingwell from Southwest Transplant Alliance, Jasmine Vega from LifeGift, Jessica Johnson at Donor Network of Arizona, and Rochelle Brown at LifeGift. So thank you all for your engaged participation during this summit, and you are each recipients of a $25 gift card to Starbucks. So if you're friends with any of these folks, make them treat you to coffee the next time you see them. So now I'd like to invite Carrie to share the winner of our top virtual poster presentation. Carrie?
Thank you, Corey. We are so pleased to receive so many outstanding virtual poster abstract submissions from this year's summit. I hope all of you took the opportunity to view their presentations and visit the presenters during the virtual talkback session this afternoon. At this point, I'm pleased to announce that based on the results of your voting, the top abstract of the 2021 National Donor Management Summit is awarded to Katrina Gaunt for her presentation about organ yield of normothermic machine perfusion procurement for DCD hearts. Congratulations, Katrina. You'll be receiving your award by mail from the Alliance shortly. And I'm sure you'll be hearing from all of these outstanding poster presenters in future learning opportunities that we hold. Well, These 2 days have gone by quickly, so thank you, as Corey said, for spending time together and for collaborating about these important topics. If you enjoyed what you heard and saw, I want to encourage you to join us as a 2022 professional partner organization. You can expect to receive our annual report in a few weeks, which will highlight all of the benefits we have that we can offer for your team. And of course, if you have any questions about the power of the partnership with us, please feel free to reach out to me anytime. I always welcome ideas and recommendations as well. And mark your calendars. We hope you'll make plans now to join us for our 2022 National Critical Issues Forum, happening in person September 13th through the 15th at the Grand Bohemian Hotel in Orlando. Efforts are already underway to make next year's forum an invaluable experience. For those of you seeking CE credits for your participation in this year's summit, please watch your email inbox for a brief post-learning evaluation upon which you'll receive your credits. Even if you're not claiming CEs, the Alliance certainly welcomes your feedback so we can continually improve our programs. At this time, I'd also like to take a moment to thank the staff here at the Alliance. Corey Bryant, Deanna Fenton, and Felicia Elizondo worked very, very hard to bring this experience to you today. Now, to close us out, I'd like to welcome Dr. Adam Schiavi back to the stage. Dr. Schiavi served with Kelly Ranum as co-chairs of the Planning Committee of the National Donor Management Summit. Unfortunately, Kelly Ranum and her team in Louisiana has had a very difficult week following Hurricane Ida. So we are thinking about them, and sorry that Kelly can't join us today. So thank you, Dr. Schiavi, for joining us to share your closing thoughts about the summit.
Thank you, Carrie. And also best wishes and hopes for a quick recovery to everybody who was affected by the hurricane. And Kelly, sorry you were unable to be with us here today because of that. So just wanted to conclude by saying that we had really a fabulous 2 days, and this morning's talk on inequities in healthcare was particularly moving. And I thank Dr. Williams, and I thank all of the speakers for all of the sessions today. I know that the brain death session stirred up a lot of activity as well, and I appreciate the speakers talking about brain death and the coming changes that may be coming down the line there that are going to affect all of us. So if you also had a chance to catch Dr. Malinowski's presentation yesterday, I really want to invite you to stick around for the Donor Management Goals Workgroup meeting. This is going to take place over Zoom, and the link can be found on the Agenda tab. This consortium of OPOs is focused on achieving specific clinical endpoints, which have been demonstrated over many years to increase the number of organs transplanted per donor, and more recently, to improve even post-transplant survival. We encourage you to stick around, learn more about their efforts, and we thank Dr. Malinowski and Jenny McBride for their partnership in aligning the work group with this year's summit. So I'd like to just leave with thanking everybody again for presenting their bold goals. I hope everybody walks away from the meeting today thinking about some bold actions, because that really is the only way we're going to have a bold impact on the world, trying to save as many lives as possible through organ donation. On behalf of the Donor Alliance and National Donor Management Summit Planning Committee, I thank you again for attending, and take care, everybody. Be safe. Thank you.